Think good evening, friends. It is 2 minutes past 8 o'clock. Without much delay, we will start the session. We expect the faculty to join us shortly. Friends, we have two important cases for the day. One is a case of a soft tissue tumor to be presented by Dr. Sri Raksha from Gadag Institute of Medical Sciences, kindly contributed by Dr. Jyoti ma'am. And the second case is again presented by PG from Kim's Gadak. This is going to be a case of varicose veins by Dr. Agwendra. First of all, I express our thanks to Jyoti ma'am for continued interest and permitting our postgraduates for this class. And we have three eminent faculty joining for the evening. And in fact, we have guests from Egypt also has coming in. So Egypt Surgical Society friends wanted to join the PG clinics. So we warmly welcome the friends from Egypt observers to join who are joined us today. And we warmly welcome the day's faculty, Professor Arka Treka ma'am, Professor Ajesh Gopal sir, and we have Dr. Ajesh Gopal. And friends, we have been doing this and we are now inching towards 5 lakh viewership, and we are closing in for 15,000 viewer subscribers. And today we have 411th and 412th cases being discussed. So with I think I thank all the faculty who have joined today and our own faculty, Dr. Sahai sir, Karnakaran sir, Srinivasan sir, and who have been having journey together all the 4 years. We have Professor Asit Patel sir, we have Professor Rajesh Gopal sir, and I trust Dr. Rekha ma'am also have joined. So friends, we have the first case of soft tissue tumor. This is going to be presented by Dr. Sri Raksha. Dr. Sri Raksha, please introduce yourself, your unit chief, and then your head of the department. Start your presentation. Thank you very much.
A very good evening to all the faculties and doctors present on the forum. I'm Dr. Sri Raksha KS, first year general surgery resident from the Department of JIMS sir, who is an assistant professor from the Department of General Surgery of JIMS in Gadak. And this case is done under the guidance of Dr. Jyoti S. Karigowda ma'am, who is the HOD of the department. So can I move ahead with the case, sir?
Yes, we warmly welcome the faculty who have joined. Rekha ma'am is here, Rajesh sir is there, and Asit sir is there. And we also welcome Professor Sameh Elgibani. Am I making it right, sir? Sir is Professor of Surgery from Egypt, Cairo. Sir is also joined with us. We warmly welcome the friends from the Egypt to join our session. So good luck to you, Dr. Sri Raksha. Please go ahead and continue your presentation.
Thank you, sir. I am presenting the case of a 58 years female who is a homemaker by occupation, resident from Gadak, who came to the hospital with complaints of a swelling over her left shoulder for the past 15 years. And the swelling is associated with pain for the past 3 years. Coming to the history of presenting illness, the patient was apparently normal 15 years back when she noticed a swelling over her left shoulder. The patient noticed the swelling while she was wearing clothes, and this was insidious in onset and gradually progressive from a size of 3 cross 3 centimeter to the current size of 10 cross 10 centimeter. There is no history of any secondary changes over the skin of the swelling. There is no history of any sudden increase in the size of the swelling. Last 3 years, the pain is of continuous dull aching type. It is non-radiating in nature and it aggravates on physical activity. There is no history of any other swellings present in the body or any similar swellings present in the body. There is no history of restriction in the range of movement of left shoulder. There is no history of trauma to the left shoulder, no history of fever. There is no history of any loss of weight or loss of appetite in the patient. Now, I would like to come to past history. The patient is not a known case of any comorbidity. She does not take any medications for diabetes, hypertension, TB, epilepsy, asthma, or any other conditions. She does not give any history of any previous surgeries. This is her first admission in the hospital. Coming to personal history, the patient has normal appetite. She consumes mixed diet. She has sound sleep, no disturbance. The bladder and bowel movements of the links in any of the family member present. Now, coming to menstrual history, the patient attained menarche 14 years ago, like her 14 years of age, and her cycles were regular, 4 days of bleeding for every 30 days of menstrual cycle. The patient has attained menopause 8 years ago. Coming to her obstetric history, the patient has 2 kids and both are living of age 20 and 22 years each. After this history, I'd like to come to the summary of my case. It is a 58 years female with no known comorbidities who presented with a gradually progressive swelling over her left shoulder for the past 15 years, which is associated with pain for the past 3 years with no other positive history. With this case summary, I'd like to come to a provisional diagnosis of a 58 years female with a probably benign swelling over her left shoulder.
Okay, Dr. Shriraksha.
Yes, sir.
Could you go back to your first slide? This is Dr. Sahai. Good evening.
Yes, sir.
Okay, so she's got pain and swelling since 15 years. Swelling since 15 years and pain.
Yes, sir.
Next slide. Next slide, please. Okay. Okay, next slide. No, is there any loss of could you ask for the motor and sensory symptoms?
Yes, sir. There were no symptoms of any
No,
change in sensations.
Yeah, can I see your slide? Because I don't think you've written in your slide.
Sir, I've mentioned about it in the examination part, sir.
Well, you should ask in the history also, shouldn't you?
Yes, sir.
If you're asking for range of movement of the left shoulder, how did you ask
Yes,
for the range of movement of the left shoulder in history?
Sir, I
That's
asked if she
more of
was
an
given.
examination. That is, range of movement is ROM is more of an examination finding rather than history.
Yes.
In history, you should ask for if there is any weakness, if there's any tingling, if there's any changes in
Yes, sir.
color of the limb. The
Yes,
whole
sir.
neurovascular bundle with the motor system and the neurological system has to be asked for in detail.
Okay, sir. Yes, sir. Yes,
Mr. Raksha?
Yes,
Hello?
sir.
Hello, am I audible?
Yes, sir. Yes, sir.
You have mentioned that there is sudden increase of the swelling since last 3 years, right?
So there is no sudden increase.
No.
sir.
I mean, there is a pain also.
Patient has only dilating type of pain for the
Sriraksha,
past
your
3
Your
you want
audio
to
is
shut
not.
your video. You
The
can shut off your
swelling
video.
has been gradually progressive.
Sriraksha, you can shut off your video if your
Yes, sir.
internet is unstable. You can save on bandwidth.
Yes, sir.
Okay, that's better. Right. Now that she's got
Yes,
pain, do you think it's an inflammatory condition? Did you ask? Would it classify as an inflammatory condition now?
Sir, I asked for the history of fever, sir. The patient did
That's
not
it.
have any.
That's it. What are the other features of an inflammatory condition which will get it?
Neither was there any skin changes. I
Right.
asked.
Did you ask for that? Did you ask for that?
Sir, it'll be associated with. Yes, sir. Yes, sir. I asked for conditions of pain.
But
I
it's
also
not there in
asked
your
for
history.
any increase.
Sri Raksha is not there in your history.
Yes,
You've
sir.
not put up it on this. Look, if it's not there on the slide, we
Yes,
presume
sir.
it's not asked, right? You might have asked,
Yes,
but
sir.
if the exam, if you don't write it on your paper, it's
Yes,
assumed
sir.
that you've not asked for it. Okay.
Okay, sir.
This particular case, you had asked for history of trauma. You're having a swelling
Yes,
which has
ma'am.
been operation and pain for the last 2 years. What were
Yes,
you
ma'am.
thinking of when you asked for history of trauma? What kind of trauma is going to cause a swelling like this?
Ma'am, any chronic hematoma I wanted to ask, ma'am, if there was any associated old standing fracture. I basically wanted to rule out the chronic hematoma.
Raksha,
Yes, sir.
this is a very big swelling, right? Since last
Yes, sir.
15,
15 years, sir.
Yes, yes. So do you suspect any malignant changes in this?
Sir, I'm actually thinking in terms of a benign swelling, sir, because of the chronic history. There is no sudden increase in the size, or there is no change over the skin swelling. There is no severe pain associated with the swelling. So I'm actually
There
thinking
is a
in more
pain
of
which
a.
has started.
Yes, sir.
So it is.
And
Can
that
you?
is the only history, sir. Apart from that,
Yes,
there is no constitutional symptoms. Yes, sir. There is
yes,
no
that
other
is
history
what.
of any loss of weight or appetite. Yes, sir. Or any wasting of the
Mhm.
muscles or weakness in the limbs. So,
So why do you think this patient is having pain now after 15 years? Something becomes painful. What could be the reason?
sir, so the patient could be having any joint arthropathies or due to
No joint
age.
arthropathy, but there will be pain on movement of the arm, and that then the range of movement would be restricted. You think there's no more restriction in range of movement?
Yes, sir. But the patient has history of aggravation of pain over the movement of the arm, sir.
So what's the severity of the pain? You've not look when you give us pain, we
Yes,
want the
sir.
whole Socrates mnemonics to be there.
Yes, sir. So
Which is
the
not
pain
there.
was, yes, sir. The pain was over the swelling. It was insidious in onset and it was dull aching type of pain. It was non-radiating. It was not, it was associated with the movement of the, it was increasing and aggravating with the movement of the limb. And the pain was mild to moderate in grade, sir.
Okay. Okay. Look, you've got two symptoms. One is a swelling, others is a pain. You
Yes,
should
sir.
your history, it just these two, it should be very comprehensive. Everything about the swelling and everything. Does the swelling increase in size? Does it decrease in size? Is there change in the size on movement? Is there change in size on contraction of the upper limb? All this has to come in your history,
Yes, sir.
which is missing. You get me?
Yes, sir.
Right.
One more point which I would like to add, Dr. Raksha, is that you should ask about the metastatic symptoms. At least some chest complaint. Okay. Hello.
Yes, sir. Yes, sir. Yes, sir. The
Like,
patient,
yeah,
yes. There is
breathlessness
no
or
history.
cough.
Yes, sir.
Yeah.
There's no history of cough, breathlessness, hemoptysis. There's no
Because
pain
it is very
abdomen
near to chest.
or
I don't
yes,
say
sir.
it is a metastatic, but
Yes, sir.
related to extension into the cavity or right.
Yes, sir.
Fine. Go ahead.
Okay, Sri Raksha, Dr. Rajgopal Sinha here. Just one or two questions.
Yes, sir.
You said it's benign, so that's fine.
Yes,
So
sir.
what are the things, just one or two, three things come into your mind at this stage?
Sir, initially, I'd like to think in terms of lipoma, sir.
Fine. What are the common, one minute. What are the common sites of lipoma?
Sir, nape of the neck, sir, over the abdominal wall trunks and extremities.
Not yet told the most common site, abdominal wall and all,
Abdominal wall. Yes,
one
sir.
minute, 1 minute. It's a part of multiple neurofibromas or multiple
Yes,
lipomatous.
sir.
Flank
Yes.
is the most common site. Flanks.
Yes.
Any other region is more common?
Sir, nape of the neck, sir.
Nape of the neck. Anything else? Supraclavicular. So supraclavicular.
Yes.
The shoulder region itself is one of the common sites. Number one.
Yes.
So we will take it later for the exam. What are the other swellings which you come into your mind?
Sir, fibromas.
Fibroma. You think the only fibromas are
What
any
is the fibroma?
Yeah, so you don't get a, only fibromatosis. You were talking about that line, or benign fibroma per se is not common. Either it's a neural, fibrolipoma, or that the neurofibroma element like that. Okay. Okay.
Dr.
Yes, sir.
Sridaksha, fibromas don't
Yes, sir.
appear alone. There's nothing, no term called fibroma.
Yes, sir.
Yeah,
It
please.
is
It
always
is generally, yes.
anything. Yes. So neural tumors. It is not
Yes.
the common site. What are the common peripheral neural sites, like a neurolemoma? What are the sites? What are the common things? Yes. See,
Sir, it can,
yes, please go ahead.
sir, so neurolemma, sir, if we're considering in terms of benign swelling, sir, if we're thinking in terms of schwannoma, it can be associated near the cerebellopontine angle.
That is
If we're thinking in terms of
peripheral.
neurolemma or the back,
But no. You have to think of which other sites we are referring to neck, somewhere here. So vagal
yes,
schwannomas. Okay, you should remember that, peripheral like
yes,
central and peripheral. So you would like to consider the shoulder region per se is not the site. What about posterior
yes,
triangle of the neck? Posterior triangle.
yes, sir, it is a common,
Why?
yes, sir.
Why?
So, sir, because there are presence of accessory nerves in the
What?
occipital and accessory nerves,
Why do you,
posterior ocular nerves.
no, why do you suddenly bring here occipital and all that accessory? Don't you have a brachial plexus there full of nerves? No? Brachial
Yes,
plexus. So Sahai sir was
yes,
asking something like numbness. So neural tumors, lipoma, yes, definitely yes. If this patient were to be a younger patient, what
yes, sir.
you would have thought of? Younger, long duration.
Yes, sir.
Yes. Younger patient means, let us say 15 years, 20-year patient with 10-year history. So to consider some vascular malformations, lymphangioma.
Yes, sir. Any hemangiomas or lymphangiomas. Yes,
This is definitely a soft tissue tumor. One look of that, anybody will tell, but differential diagnosis, they will ask you.
yes, sir.
Shoulder limitation.
Yes, sir.
Movements of the shoulder, bursa, chronic bursitis. See, so many discussion can take place. So a
Yes,
few
sir.
things you know. So what question you are asking to your patient, and what is the shoulder region here per se? Mild, moderate, severe intensity you have mentioned. More than that, you should have asked limitation of the movements whenever he moves the shoulder in particular angles. Okay.
Yes,
The day-to-day activity involves day-to-day activity, shoulder, day-to-day activity, correct? So whatever you
yes,
want,
sir.
that's all. These are the few questions. Yes, sir.
Shankar. I am just coming. I need to wait.
Sridaksha, can you please go ahead with your presentation?
Yes, sir.
I think, I don't know. I just want to also tell you, MS
Yes,
examination,
sir.
this is a short case for you. So,
Yes, sir.
in a case like this, unless it is related, just go back to that one slide. Detailed menstrual history, all the things are not required unless you have a patient like that. Just hold on.
Yes,
Yeah. So,
yes, sir.
gradually progressive swelling, one important issue. Second is presence. Many other swellings in the body, multiple swellings. Okay.
Yes, sir.
We can see that I think you have a problem of electricity. Doesn't matter. Suddenly we saw you in darkness. So multiple swellings in the
Yes,
body,
sir.
multiple swellings in the body,
Yes, sir.
then pain, you have mentioned. Then sir has already pointed you cough.
Yes, sir.
Cough. That is very important.
All the metastatic. Yes, sir.
Yes, because why cough is important? What prompted you to ask that question? Why not abdominal distension?
Sir, in case we're thinking in terms of malignancy, sir, it is generally hematogenous malignancy. Lung is one of the most common sites where malignancy occurs.
What hematology?
So,
Sorry, what malignancy you are suspecting? If at all.
sir, if I'm thinking in terms of liposarcoma, I'm thinking about liposarcoma for the case, sir.
Any
So that
soft tissue
generally
sarcoma.
spreads
Any
to
soft
the lungs. Yes, sir.
Okay, your answer should be malignant transfer, whatever. Anyway, let us not talk
Yes.
about transformation. We'll only say if you are thinking in terms of liposarcoma, lungs you are trying to think. So I would like to ask the question of cough. Yes, madam
Yes,
is already Jyoti madam. Yes, please.
Dr. Sri Lakshmi, about
Yes,
you,
sir.
you had told me about skin changes. Are there any other
Yes, sir.
skin changes which you're interested in this case?
Sir, I'd like to think about any discoloration of skin, any ulceration, or any extra growth or fungation over the swelling.
What about cafe au lait spots?
Yes, sir. If it is present in neurofibroma, sir. So,
No, I mean,
but it is present throughout the body, sir, not just
well,
particularly
in your
over the
history,
skin.
you should ask. In your history, all this
Yes,
has.
sir.
Look, when you
Yes.
when you get a case,
Yes,
you
sir.
come to a differential that what could be these, and then you should go back
Yes.
to your history and see whether you have ruled out each of these things by
Yes.
your history, right?
Yes.
So you
Yes.
will be able to ask those points only if you know that this could be your differentials and what are the characteristics of each differential,
Yes, sir.
right? So should we proceed to examination? Hello.
Sir,
Okay.
Raksha, you can go with the examination part.
Now coming to general physical examination, after taking consent from. Yes, sir. Can I continue? Yes, sir.
Yeah, please.
After taking consent from the patient was examined in a well-lit room. The patient is moderately built and nourished, conscious, cooperative, oriented to time. Yes, sir.
No, go on.
Sir, can I continue, sir?
Yeah, please. You may put your video off and continue.
Yes, sir. Yes. Yes, sir. The patient is moderately built and nourished, conscious, cooperative, alert, and is oriented to time, place, and person. There is no pallor or pedal edema. Now coming to vitals, the pulse rate is 82 beats per minute, measured in the right radial artery. It is of regular rhythm, volume.
Oh dear, we lost. Yeah.
The BP of the patient was 130 by 80 mmHg, measured in the right brachial artery in sitting position. Respiratory rate was 18 cycles per minute, and the BMI of the patient was 22. The patient is afebrile to touch.
Yes, go ahead.
Now,
Local exam.
coming to the local examination of the shoulder.
Raksha, you can please go ahead. I think there's
Yes, sir.
some disturbance is there. I don't know.
I'd like to start with. Now coming to inspection, I'm talking about the examination of the left shoulder. After taking consent from the patient was adequately exposed from the neck to the mid umbilicus, and the patient was examined in standing position with arms by the side of the body. On inspection, there is a solitary 10 cross 10 centimeter globular swelling present over the left upper arm in the upper aspect around the left shoulder joint, which is 10 into 10 cross centimeter with well-defined borders superiorly, laterally, whereas medially the swelling extends towards the chest wall and is ill-defined. The surface of the swelling is bossylated with dilated veins appearing over the swelling in the anterior superior aspect, and the skin over the swelling appears normal. The surrounding area also appears normal. In this picture, we can see the superior and lateral aspect of the swelling. We notice that the swelling is more prominent in the lateral aspect. Now coming to palpation, there is no local rise of... Yes, sir.
Dr. Akshay,
Yes, sir.
you said the swelling is globular.
Yes, sir.
Just correct it. It is a spherical. Cannot be globular.
Okay, sir. Yes, sir.
Okay, fine.
Yes, sir. Now coming to palpation, there is no local rise of temperature. There is no tenderness over the swelling. The inspectory findings like site, size, shape, and surface of the swelling is confirmed. The swelling is soft in consistency, non-fluctuant in nature. The borders, as mentioned earlier, are well-defined superiorly, inferiorly, and laterally. The skin over the swelling is pinchable, and the plane of the swelling is subcutaneous. I mean to say that the swelling was freely mobile in horizontal and vertical directions, and it was not fixed to the underlying muscle. There is no restriction in the passive range of shoulder joint movements. There is no axillary or cervical lymphadenopathy. Now coming to distal pulses, the brachial, radial, and ulnar artery are found to have normal volume and are as comparable to that of the opposite limb. There is no change in the pulsations, and there is no loss of sensations over the distal part of the limb after the swelling, be it sensory or motor. Coming to systemic examination, all the systemic examinations appeared normal. The cardiovascular, RS, abdomen, and CNS findings were normal without any significant changes noted.
So what is your clinical impression?
Sir, she's a 58 years female with a benign swelling over her left shoulder, probably a lipoma.
Benign and malignant, they are basically pathological diagnosis.
Yes, sir.
So don't say benign. You can say it's a lipoma. Fine.
Okay, sir. Yes, sir.
Why
So
this
I'm
is
thinking
lipoma?
of a lipoma.
Huh?
Yes, sir. Now, starting with history, sir. There is a chronic history which is slowly progressive in nature. With the examination, and also I'd like to talk about the age. She is an adult, which is also one of the common age group for lipoma. With respect to the inspection, with respect to the examination per se, in inspection, it is a spherical swelling with lobulated surface, normal skin over the swelling, and on palpation, it is soft in consistency and it is non-fluctuant in nature. Also, I'd like to add that the slip sign was positive in this case, sir. All of these findings are...
That is pathognomic sign.
Yes, sir. All of these clinical examination and findings are more towards lipoma, sir, which is why my diagnosis is a lipoma.
Any points against to this?
Sir, I noticed that there are few dilated veins
Yes.
present over the swelling. So, generally, that is not present in a lipoma. That goes towards a liposarcoma or any variation of a lipoma like nevolipoma.
Nevolipoma. The swelling is compressible.
So no, sir, it is not compressible, sir.
Okay. Any differential diagnosis would you like to put for this swelling apart from lipoma?
Sir, as mentioned earlier, any nerve tumors or nerve sheath tumors, or because
No, Dr.
because of this...
Dr. Sriracha. Just don't say nerve sheath tumor. Give us a specific name. Right? You should be specific.
Like lipoma, you say.
Like you say, lipoma, where? Your diagnosis should be lipoma, right shoulder or left shoulder at this plane. It should be
Yes.
complete. You just
Yes,
can't.
sir.
Like you're saying, she's an adult. That means no, sir. Tell her that's the age.
Yes.
Be specific. Yeah, go on.
Yes, sir. Yes, sir. Sir, because of the dilated veins present over the swelling, I'm also thinking in terms of sarcoma. So my other differential diagnosis is a soft tissue sarcoma, maybe a liposarcoma.
Dr. Rakshika, you shouldn't be swinging back and forth in terms of diagnosis. Either you stick with a benign or you go with the malignant, all right? So a good
Yes, ma'am.
diagnosis here would be a soft tissue tumor. And you're thinking in
Yes.
terms of, you wouldn't just
Like-
say it as a tumor, you qualify it and you say it as a subcutaneous encapsulated lipoma over the left shoulder. That would be your
Yes, ma'am.
diagnosis. Saying lipoma is like an undergraduate representation, all right? Then the moment they ask you what
Yes,
what is your differential, don't swing the other way and immediately say malignancy. If you thought in terms
Yes,
of
ma'am.
benign, and in this particular case, when you have the presence of dilated veins present, it's very visible even in the photograph. I don't think you
Yes,
should be so categoric in saying just a lipoma. You would think in terms of a soft tissue tumor,
Hemangioma. Yes, ma'am.
like rule out a malignancy as well. All right, don't be so fixed and say it's only a lipoma. You always
Yes.
till such time as your investigation proves it. All right. So when
Yes,
you say
ma'am.
diagnosis, also make sure it is complete.
Yes, ma'am.
Dr. Dalvi, I think you raised your hand, sir. Sir, Professor Dalvi.
Yeah, good evening.
What is-
Just describe the inspectory findings of the skin again. Apart from
Yes.
dilated veins, are you seeing something else?
So the skin is shiny and slightly stretched, sir.
And see the color of the skin
So there is
as compared to normal tissue. Does it look a little red to you?
yes, a
Could you
little.
show us the picture again, Dr.
Yes,
Raksha?
sir.
Show us the picture again.
The slides are actually not there. I mean, I don't know. I can't see the slides.
No, I have seen it on the thing that Kanakbel has sent us.
Sir, she was presenting here. Now slides are right now. I don't know where they are. I can't see. Can you share again, Doctor? I think
Yes, yes.
there's some power failure. I don't know, power failure problem. I don't know.
I'm sharing it, sir.
Show that picture once.
Yes, sir.
Is it possible to zoom a little bit of that, Dr. Sri?
Yes, sir.
Just very good. Okay, stop at this. Little go away, go
Yes,
away.
sir.
Zoom out a little bit. Out. Zoom in. Zoom in.
Yes, sir.
Okay.
There is one more slide which shows it. Maybe the previous one or the next one. I don't know.
Raksha, just watch that swelling. Just show me that swelling which you showed. Down.
This one, sir.
Enlarge, sir. I think you meant this one, sir. The veins are seen. Yeah, just stop this.
No, the next one. Next one.
Yeah, the one from the side. That looks very suspicious.
Correct. The right side one.
Sri Raksha, one more thing I would like to tell you also. There's a very
Yes.
classical, in addition to the slip sign for palpation, you
Yes, sir.
show that first picture, zoom in a little bit, zoom in. Okay, stop. If you see
Yes, sir.
carefully, can you see some dimples there? Dimple.
Sorry, sir. I couldn't hear.
Dimple.
Yes, sir.
Can you see that?
Towards the inferior. Yes, sir.
Show
Towards the
the
inferior.
picture, sir. This you can show, I suppose. I think all can. Oh God. Yeah. Yeah. You can see now what is the reason for this dimple. You don't find this in neural tumors or hemangioma, lymphangioma, dermoids, etc. See
So the
carefully.
capsule, yes, sir. The capsule of the
Yes,
lipoma has fibrous attachments to the skin, sir.
exactly. This is a very important sign. Okay, if you try to move this swelling, no, you
Yes,
just
sir.
get an impression that there's some kind of a septa you are pulling from the skin. You know, this is
Yes.
the actually septa which are attached to the skin. One of the features of a lipoma. Okay, right. That's all from my side. What test which you have done? I saw some movements of the shoulder there for you to check probably that it's a subcutaneous swelling. Since you said some
Yes.
dilated veins are there, you are worried. So what is that you are contracting now in this?
So we're contracting the deltoid muscle, sir. So upon contraction of the deltoid muscle, the swelling appears more prominent, and over the abduction also, the swelling is appearing prominent, sir,
Can't hear
which
you.
means it is not fixed
Can't hear you. Off your video and speak, Dr. Raksha.
Cutaneous. So we have corrected the dead muscle. So to infer swelling, yes. Yes, sir. Sir, am I audible now, sir? Sir, can you hear me now?
Yes, you are better. You are better.
Yes, sir. So I have put the underlying deltoid muscle into contraction, sir, in this slide. So when we're in the abducting position, muscle is
See, we can't hear you, Dr. Sriraksha. I don't know what you spoke. So what is the initial abduction? Which muscle carries the initial abduction?
Sir, 0 to 15 is supposed to be supraspinatus. 15 to 90 degrees the deltoid muscle, and 90 to 180 is the serratus anterior muscles.
So whatever the muscle contraction which you are doing, always remember it should be against resistance. Okay.
Yes, sir. Yes,
I
sir.
hope, we can't see that. I hope you have done that. Whatever muscle, whichever is you are contracting.
Yes.
Okay.
Yes,
That
sir. We have contracted the deltoid muscle, sir, in this. And the swelling is more prominent upon contraction of the deltoid muscle. So it means that the swelling is not fixed to the underlying muscle and it is subcutaneous in plane.
So when you are contracting the muscle, there are two things you should remember. It is not about the plane which you are told just now, subcutaneous. That
Yes,
means
sir.
it is more prominent. You also should check for the mobility
Yes,
before,
sir.
before and after, especially such a
Yes,
large
sir.
patient where you told some dilated veins are there. So you have
Yes, sir.
mentioned mobility in both direction, whichever direction which you mentioned initially.
Yes, sir. Both
Alright.
along the fibers of the muscle and perpendicular, sir, the swelling is mobile before and after contraction of the underlying muscle.
So,
There will be no power and going down.
You have mentioned that sometimes that swelling is soft. I think you mentioned lobular. I don't know what we heard properly. And you said no fluctuation, correct?
Yes, sir.
So consistency was throughout soft.
Throughout, so uniformly soft.
So this is one of the points which you need to mention in all these soft tissue tumors. Variegated consistency is also known. Areas of
Yes.
softness, areas of, some kind of a whatever with the malignancy in this patient or some other patient. So
Yes,
if
sir.
it is so in such kind of a lipoma, do you expect a degree of fluctuation?
So fluctuation is, sir, it is actually possible, sir. In few, few of the adipose
Possible,
tissue can,
possible, or it was positive in your case? I just want to know.
sir, it is possible, sir, but it was negative in my case.
So the whole thing was so soft and you could not get any fluctuation, correct?
Yes, sir.
So what do you think the reason why we say, lipomas, you get some fluctuation, even though it's a solid tumor?
So few of the adipose cells can be in the liquefied state, sir, which is why there can be a pseudo fluctuant condition, which is why we call it pseudo fluctuant.
So you should look for this sign very carefully. Okay, then
Yes.
if it is a fluctuation is negative, then there's no question of further mentioning about all this transformation and other things like
Yes.
compressibility. What is the difference between, especially soft swellings? They may ask you this question: what is
Yes.
compressibility and what is reducibility? When do you say this swelling is compressible? Hernia, we say reducible, no? Correct?
Yes, sir.
So
Sir,
what
when
do
it is a, yes, sir.
yes, please go ahead.
When it is a reducible swelling, sir, the swelling one reduces in size and then completely disappears. Whereas in compressibility, there is reduction in the size initially, but once the pressure is removed, it regains its original size. There is no
Okay.
complete disappearance of the swelling.
Complete, okay, but more importantly, the pressure and counter pressure. Okay, counter pressure. You reduce the hernia and then you ask the patient to cough. Correct? Correct? Hello. Hello, you are there or you disappeared? Madam, we can't hear you. Jyoti, madam, I think you are muted. Where is your candidate? Madam, Jyoti, madam, you are muted.
Hello, can you hear me, sir?
Yes, yes, yes.
Sir, there is no power since morning, sir. That's a problem. They prepared that's what I call them. So the internet connection is there. So they're trying with the dongle. So she'll come back, I think so, sir. shortly.
No issues.
Rajgopal, I think we can go to the other candidate and they can wait till they settle the issue.
We have almost finished the clinical examination. I think just probably diagnosis and treatment. Dr. Sai, sir, and
No, because investigations also, have important role in surgery in these cases.
Yes.
Planning of surgery, especially in any soft tissue swelling where there is a doubt between benign swelling and malignant swelling, requires a lot of work. And let us give her enough time. What is the problem?
yes, where?
If the
Raksha, you are there, or I think.
So we can call the next candidate, sir.
Yes, 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 sir.
Sri Raksha? I think our connection has lost, sir.
No. Is Dr. Kadapur around?
Hello, sir. Shanai, sir.
Dr. Raghavendra.
Sir, yes, sir. She will be back with a mobile, sir. She is connecting, and both are presenting from the same place.
Okay.
So the same problem is there with him also.
Okay,
So they are
okay.
going to start, sir, shortly.
Okay.
Sorry for the inconvenience.
We'll
sir.
wait.
Okay, thank you so much.
Till then, I'd just like to say that,
Huh?
like Professor Dalvi said, investigation
Yes.
is very important here.
Yes, sir.
Right, they will.
Hello, sir.
Sorry.
She is back, sir. She'll.
Right.
We have done certain
Yes.
relevant investigation. She will deal with that, sir. Okay, sir. Thank you, sir.
So sorry, sir. There's a network issue here.
Yeah. You continue, ma. If that is network issue, you take off your video and you share the MRI and the core biopsy, whatever it is, or FNAC, what is done. No, they're going for a
Yes.
investigation. You just continue with them. Thank you.
So for the time being,
Yes,
the
ma'am.
other candidate where varicose veins we are seeing the slide, please unshare, and so that she can put the MRI or whatever slide if it is available, please.
Yeah, available, sir. Raghavendra, you unscreen na your please unscreen it. Hello, Raksha. Hello.
Yes, ma'am.
Yeah. Ask
Hello. Yes, ma'am.
Raghavendra. Yeah. Share your investigation list, na?
Yes, ma'am.
Dr. Raksha,
Yes, sir.
can you hear me? Yes. Okay.
Yes,
This
sir. I
is
can
Dr.
hear.
Gopal. So in this case,
Yes, sir.
which would be your order of investigation? Like, which one would you do first, the imaging or cytology or biopsy?
So
Or
as
whatever?
yes, sir.
And why?
Initially, I'd like to go ahead with a radiological diagnosis, sir. So as an extension of my clinical examination, I want to go ahead with an ultrasound of the swelling.
Okay.
This is the first investigation that I would want to do because we don't know what we're not sure what the underlying structure is. We do not want to go ahead with any tissue diagnosis at the moment. So we have gone ahead with ultrasound of the swelling, sir.
Yes.
And in ultrasound, we have noticed that there is a 4.3 cross 2 centimeter isoechoic lesion with multiple echogenic fatty strands in the subcutaneous plane noted over the deltoid region, which was suggestive of a subcutaneous lipoma. Once we got this investigation, sir, we went ahead with fine needle aspiration cytology of the swelling, which is the tissue diagnosis. And in this, we have noted we've seen that there is cellular and cohesive clusters of benign mature adipocytes scattered in a lipoid band, reinforcing our initial clinical diagnosis. Now, once we have reached this, we also got an X-ray to check whether there was any bony involvement, sir. In this, we noticed that the joint is normal and there is no bony involvement. Towards the right-hand side, we can also notice the soft tissue shadow of the lipoma present over the shoulder joint. Once we got this, we also went ahead. Yes, sir.
So these are the investigations that you did.
We also went ahead with MRI of the swelling. Yes, sir. We've also gone ahead with MRI of the left shoulder. So we wanted to check for the extension of the swelling.
There is some problem with the audio.
The MRI spoke about a subcutaneous lipoma overlying the left shoulder, contour of the deltoid muscle. There was minimal acromioclavicular jointopathy and minimal supraspinous tepathy. So this both swelling of 10 cross 10 centimeter present both in AP view and axial view. This was suggestive of a subcutaneous lipoma. There was no underlying joint involvement. and it was present above the deltoid muscles. These are the investigations that we have gone ahead with. So
Okay,
in the
that-
radiological,
I think there is some problem with the audio again.
Hello. So I have a few queries till she joins back. I joined in late, so I don't know if they've been addressed or not. Has she examined other muscles besides deltoid?
ma'am, we have, yes, ma'am, we have checked for coming from posterior anteriorly. We've looked for trapezoid muscles. We've also checked for supraspinatus because it is involving in the shoulder girdle. We've also checked for serratus anterior, although the extension of the swelling was not noted until
Very
the
nice.
end.
And even pectoralis major, I hope, because it's grossly overlying that
ma'am.
area.
Yes,
And
ma'am.
did you, I hope you also checked for any intra-articular extension. How did you check for it?
Ma'am, one we checked for the range of motion of the shoulder
Yeah.
joint, ma'am.
Okay. How
Along
did you find out whether there was any intra-articular extension or not?
ma'am, one along with the movement of the shoulder, there was no change in the swelling
Very good.
size or shape of this the
Very
swelling.
good. And any neurological examination was done by you?
Yes, ma'am. In all the distal regions, we have checked for the sensations over the skin. It was intact. There was
Why
no
only
change.
distal
And
regions? What is the nerve which is likely to get involved in this case?
ma'am, actually, axillary nerve, which supplies that area, could be involved.
So you did the sensory and the motor examination for axillary nerve?
Yes, ma'am. Yes, ma'am.
So which area did you look for sensations?
Ma'am, we've looked over the lateral aspect of the arm, ma'am. Because
You have to look over the shoulder
yes, ma'am.
for
Over the
sensation.
shoulder. Yes, ma'am.
Movements you've already checked. I
Yes,
noticed
ma'am.
in the
Movements we've
image that
checked
there was some dermatitis over the forearm. Is there any exposure to sunlight or radiation? Am I
no,
right?
ma'am.
Am I wrong? Because there seems to be a very gross difference in the color of the upper part of the arm and the lower half of the arm in the forearm. Is there any gross exposure to sunlight or UV radiation? What is his
No, ma'am.
occupation?
The patient is a homemaker, so there is not much exposure to the sun. She does not have any history of farming, so there is not much sun exposure present, ma'am.
Thank you so much. Sorry for interrupting the investigation part of it. Please continue.
Thank you, ma'am.
Well, yes. Suppose you had been suspecting a sarcoma in this case, like you
Yes.
mentioned in your differential diagnosis.
Yes, sir.
What would be your next approach for completion's sake?
Sir, so
MRI.
after, yes, sir. We would go ahead with MRI, sir. It is the gold standard investigation in terms of a soft tissue sarcoma.
Yeah, after MRI.
Yes, sir. After MRI, we would actually plan for surgery, sir. Like because we would go ahead with FNAC is not sufficient, sir, when we're thinking in terms of a soft tissue sarcoma. So I'd like to go ahead with a core biopsy with adequate precautions taken. We would like to go with a core biopsy to check for the cellularity, if there was any necrosis associated, to come up with a grading. And then we would, depending whether it was a high grade or a low grade, we would plan the next further step.
Okay. Is there any rod for any incisional biopsy if the core biopsy is not satisfactory or it doesn't yield any result?
Yes, sir.
Is there
We
any
can
rod?
go
Yes.
with incisional biopsy, sir, but there are few principles which are to be considered.
Yes,
Like
what
it
are
has to
those?
be performed by the same operating surgeon who does both the biopsy and then the surgery ahead, and it should be generally vertical. We do not go for a transverse incision. And whenever we take an incision, we should make sure that it is only in one compartment and it is not injuring any other structures. And when we finally go ahead with the excision of the swelling, which is the wide resection, we should make sure that the initial incision site is also taken in the swelling so that there is no chance for any recurrence or spread of the tumors.
Any other precautions that you would like to observe while doing this biopsy, you would probably avoid a drainage, any sort of
Yes, sir.
drain,
Yes, sir. We would not like
isn't
to
it?
keep anything. Yes,
And
sir.
you'll try to keep the hemostasis at its
Yes,
best.
sir. Yes,
Okay.
sir.
Okay.
So once we have got the diagnosis, sir, we can go ahead with the resection. So the resection has to be wide local excision with a minimum of 1 centimeter margin.
In which case, in your case, or
No, sir. If we are thinking in terms of soft tissue sarcoma, sir, in my case, there is an excision biopsy which will
Okay.
provide adequate for the case.
back to the soft tissue tumors, sarcomas, which are the
Yes, sir.
commonest types of soft tissue sarcomas that you come across
The liposarcoma
in
is the
terms of
commonest.
incidence?
So liposarcoma is the most common type of soft tissue sarcoma, followed by malignant histiosarcoma, sir.
What is the new name for that? Malignant fibrosarcoma. There is a new name that comes around 20% in terms of incidence.
They're
That is now known as
unspecified,
high-grade undifferentiated pleomorphic sarcoma.
undifferentiated pleomorphic sarcoma.
Yes. What are the other tumors?
So there is rhabdomyosarcoma, synovial sarcoma, fibrosarcoma, hemangiosarcoma, and
Synovial sarcoma, yes. Which are
synovial
the
sarcoma.
soft tissue sarcomas that metastasis through lymph nodes?
Sir, so synovial sarcoma, sir. Apart from that, rhabdomyosarcoma, then
Okay.
angiosarcoma and
Clear cell sarcoma, A-wings
yes, sir. Clear cell sarcoma. Yes, sir.
and A-wings.
And remember,
Okay.
remember it through RSS, RSES.
Yes, there is a
Rhabdomy-
code. Yes, yes. That mnemonic is quite helpful.
Yes, sir.
Can I ask a question?
Yes, sir.
Please.
When you send this patient for investigation like ultrasonography or
Yes, sir.
MRI,
Yes, sir.
what will you discuss with a radiologist or a sonologist? What do
Yes,
you
sir.
want to know out of the investigation?
Yes, sir. So we'd like to know about the plane of the swelling, whether it is in subcutaneous or if it is
No,
infiltrating the
you answer in two the phases, ultrasound and MRI.
So with ultrasound, initially we'll speak about the consistency of the swelling, sir, and then the extent of the swelling.
In
The plane of
lipoma,
the
what do you expect? No, 1 minute, listen to me.
Yes, sir.
In this patient, this is puckering, which has been pointed out to you, as especially on the skin. So, where a sonologist is concerned, what do you expect out of him or her? And MRI, what do you expect out of?
So when we're talking in terms of ultrasound, sir, we'd like to get to know if it is a diffuse swelling or an encapsulated swelling. Hello.
Correct. What else? What else? What else? How will it
Yes, sir.
differentiate raising suspicion of malignancy?
So the margins of the swelling, sir, if it is well defined, or if it is not involving the deep structures, it is more benign. And if there is no increased in vascularity of the swelling, then it is more in terms of benign
That is more important,
malignancy, sir.
vascularity of the
Yes.
swelling. In
Yes, sir.
MRI, now when you ask for MRI, you are already planning
Yes.
surgery, right?
Yes,
Or
sir.
some other treatment. What are the
Yes, sir.
things that you want to extract out of report of MRI?
Sir, in MRI, we'd like to get to know about the extent of the swelling, sir.
What else?
And then for operability, we'd like to know what incisions are more preferable, how we can
No, no,
approach
no.
this well.
Sir is asking something very important. Otherwise, you
Yes,
get
sir.
it a simple ultrasound. Why should you need an MRI? What are you looking for particularly in MRI?
I'm asking this question because she wants to do biopsy even before MRI.
So if
Any
there's any
neurovascular
vascular
extension?
component,
Exactly, neurovascular extension, involvement of the nerves, involvement of the vessels. That's
yes, sir.
important. We're going to excise a large tumor from the upper limb, which will compromise the blood supply, nerve supply lower down.
Yes, sir.
So you got to be sure, no? Otherwise, you
Yes,
go
sir.
into amputation if you leave the limb hanging around. That's why.
Yes, sir. Yes, sir.
My next question is X-ray of the left shoulder. What additional information is it going to give you?
So one, if there is any
See,
associated
1 minute.
joint
Listen to me.
Yes, sir.
Clinically, shoulder is normal,
Yes, sir.
correct? Still, you want to do
Yes.
X-ray because you
Yes,
gave
sir.
a weak diagnosis of some synovial carcinoma.
Yes, sir.
You talked about it, right?
Yes, sir.
That's the reason you wanted to have X-ray. It is never in your differential diagnosis that it can be arising from synovial. So
Yes,
tell
sir.
me the reason why you want to do a X-ray of the shoulder joint when movements are normal. Clinically, you know it is separate.
Yes, sir. So joint space we can see in the swelling. If there is any increase in the space, it could be a
That you will see in
synovial.
MRI also.
Any joint arthritis or arthropathy can be.
How does it change your treatment?
It doesn't, sir.
So don't over-investigate patients when you're doing higher investigation. That's the way I would look at it.
Yes, sir.
I am an old man. I will still do X-ray to know because I have seen more X-rays than MRI. But remember, there can be examiners who will just surround you with all these investigations. Go ahead. You're doing
Yes.
well.
Yes, sir.
You have a choice between X-ray, ultrasound, MRI, CT. You have to do only
Yes.
one investigation.
So I'll go ahead with MRI, sir.
Good. Agree. And you are planning to do excision biopsy in this patient?
Yes, sir. As treatment, sir, I'm planning to go for excision biopsy.
No, it's not for the
Because
planning.
my
Excision biopsy is
radiological and
not done for the
cytological.
planning.
So just excision, sir. We would further send the specimen for HPR, but that is a better step. The treatment
What
for
is
the
the size
patient,
of the swelling?
it's a 10 cross 10 centimeters, sir.
So in a 10 cross 10 centimeter, you will do excision biopsy. You know what are the limits of the incision and the excision biopsy? When you can do incision biopsy and when you can do excision biopsy. The term excision biopsy, not the planning. Excision biopsy.
So less than 5 centimeter can be used for
5 centimeter is again a too big one. Too big. If it is less than 3 centimeter is there, you can plan for the excision biopsy.
Yes.
If it is more than that, then you have to think of something else. You cannot do excision biopsy. So in this patient, probably there is no question of doing excision biopsy. Okay.
Yes, sir.
For the diagnostic purpose. Yeah.
Yes, sir.
So what would the term be then? You can't do an excision biopsy?
The resection.
You do a wide local resection.
Yes, sir.
That's it.
You said the liposarcoma is the commonest one in this area?
Sir, in general, sir, when compared to incidence, liposarcoma is one of the it's the most common type of soft tissue sarcoma present.
What is the commonest site of the liposarcoma?
Sir, it's present in extremities or in the retroperitoneum regions.
In the extremities where it is more common?
Sir, lower limbs, sir.
In the lower limb where
In
it
the
is more
thigh
common?
region, thigh, sir.
In the
Proximal
thigh.
part.
Yeah. In the gluteal in the thigh region, yeah.
Yes, sir.
Lower limb proximal region.
Regarding the incidence.
Yes,
yeah,
sir.
please, sir.
So I'm going
Regarding
to go back to the question. How do you classify lipomas? Because you're going with a benign diagnosis, right? So how do you classify lipomas?
Ma'am, lipomas are classified into diffuse type, encapsulated type, and multiple lipomas.
Any other classification?
In terms of tissues?
Based on the content or the tissues, it can be divided into nevolipoma or hemangio. Sorry, that's the same as nevolipoma. That is
Angiolipoma.
Angiolipoma, fibrolipoma,
Neurolipoma.
neurolipoma. Yes.
As per the location?
Certain location, it is present in subcutaneous plane.
Yes.
It
What
can
are
be
the other
present
planes
in
where it can be?
Sorry, sir.
What are the other planes where you can get a lipoma?
Yes, sir. It can be intramuscular, intermuscular, subserous, submucosal, subperosteal. Then it can be extradural in spine region.
What was that subperiosteum there?
Beneath the periosteum of the bone.
So it's paraosteum.
Yes, ma'am.
All right. Periosteum.
Yes. Yes,
You
ma'am.
don't both. All right.
Yes, ma'am.
There are
You said
10 of
mature.
them. I'm sorry. There are 10 of the planes in which lipomas can. You have told me 7.
Sir, apart from this, it is both intra and intermuscular, sir, which will be called as infiltrating lipoma.
See, I'll tell you something. When you
Yes,
talk like this, you're opening plethora of questions on you.
Yes, sir.
What is intra and intermuscular? Tell me difference between the two.
Sir, in intramuscular lipoma, sir, it's present in between two muscles, whereas if it is
No.
intermuscular, it can
Inter is between two muscles. Intra is within the muscle. Intramuscular means within the muscle.
Yes, sir. Intermuscular is in between.
Can it be within the joint cavity known as intra-articular?
Yes, sir. It can be, sir.
There are 5 S's, 2 I's, and 3 P's. Go back and read.
Yes, sir.
Very easy to remember. 5 S, 2 I, 3 P's.
Yes, sir.
Go back. Homework.
Yes, sir.
Okay.
You use the word, it's a tumor of mature adipocyte, right? So
Yes,
can you get
yes,
a tumor of the type of tumor from immature fat cells?
Yes, ma'am. We can get, ma'am.
You want to answer that?
Like yes, ma'am. If you're thinking in terms of liposarcoma or liposarcoma, ma'am, it can arise from immature adipose cells.
What is a lipoblast?
Ma'am, lipoblasts are immature. They're the precursors of adipose cells.
What is brown fat?
Ma'am, in pediatric cases, like what we notice around the neck region, like it consists of like there is high metabolism present and it acts as an energy source in pediatric cases, ma'am.
Just energy, or does it do any other function?
Ma'am, it will also help in maintaining the temperature of the child.
What is the
Provide-
tumor that arises from brown fat? Is there some terminology?
Yes, ma'am. It's called. Ma'am, I can't recall, ma'am, but I remember reading it.
It's fibernoma.
Yes, ma'am.
Fine.
Okay, by the way, in terms of incidence, what was the commonest that you mentioned? Is it liposarcoma? That is the commonest type of sarcoma?
Yes, sir.
Uh, actually, leiomyosarcoma has also got around 20% incidence. So
Okay,
liposarcoma, leiomyosarcoma, MFH, both in that territory. Then comes synovial sarcoma, MP, NST, and all that. So leiomyo and lipo,
Yes,
almost similar incidence, around 20%. Okay.
yes, sir.
Is Derkam disease?
So multiple painful lipomas present mostly over the abdominal wall of the trunk. It is a neurolipoma. So
What is the other
it's
name of
present
that?
all over the abdomen and trunks. It's also called as adiposis dolosa.
In what way the grading is important in STS? Any idea?
Sir,
Why is grading so
yes, sir.
important in?
Sir, like if it is a low grade, sir, it is less metastatic and it can be managed with initial surgery followed by chemotherapy. Whereas if it is a high grade, we would like to go ahead with the neoadjuvant chemo or radio, which is then followed by wide local resection of the tumor, sir.
Yeah, correct. So what are the factors considered for grading in histopathology?
So one is the
yeah.
cellularity, necrosis compound, and then mitosis factors, sir.
Yes, pleomorphism and differentiation also.
Yes.
Okay.
Where will you put the incision?
Sorry, ma'am, I couldn't hear.
I want to plan the incision for your excision for this patient. You said you want to do excision, right? You're thinking in terms of a lipoma. You want to excise it, right?
Yes,
Where
ma'am.
do you want to make the incision?
Ma'am, over the superolateral aspect of the swelling, ma'am. We'd like to go ahead with.
You want to cross the joint?
No, ma'am.
You said superolateral, right?
Yes, ma'am. No. More on the lateral. I would like to go ahead with the lateral incision over the swelling.
So in this particular case, you'll have to have the patient move and see where your crease lines form, all right? So that you sight it along the point so that it doesn't restrict the movement. Because a benign tumor, you go and excise, you give us results in a scar contracture, you're going to have a bigger problem compared to leaving her with a benign. All right?
Yes, ma'am. Yes, ma'am.
So some even go circumferentially if necessary. You have to plan for it with the moving arm in order to plan your. As far as possible, try not to cross the joint.
Dr. Sri, suppose the patient says, I don't want any excision. I want to leave it like this.
Yes, sir.
What could happen to this lump?
Sir, it could undergo complications. Most likely it wouldn't because lipomas do not have major complications rate. If the patient is undergoing any complication, there could be any myxomatous degenerations.
No,
The
it's a
patient
lipoma.
can undergo
It's a
cancer.
large lipoma. It's a large lipoma. What could be the complication in a large lipoma?
Sir, we could think about sarcomatous changes, sir. But it is also to be noted that for a sarcomatous change, For a
No, you
sarcoma,
tell
it is
me
changed gently de novo.
Okay, one is sarcoma. Fine. What else? What are the common results of complications of a lipoma, such a large lipoma left behind?
So there are calcifications present, there are saponifications and myxomatous changes. And with recurrent exposure and friction, the patient can develop ulcerations and changes over
Right.
the.
So ulceration of the skin. That's one.
Yes.
You have to convince the patient that he's got to get it removed. No? If you tell him there's
Yes,
going to be calcification, he says, so what?
Yes,
How is
sir.
he bothered if there's calcification? So what
Yes.
will he tell him will happen to the slump if you don't excise it? One is okay, the skin can get ulcerated. What else? More commonly,
There's infections and hematoma into the lipoma can cause severe pain.
It'll stretch the nerves, it'll stretch the muscles, it'll stretch the blood
pain.
vessels. Yeah.
It can
These are the
cause
common
severe pain and pressure symptoms.
distortion of the arm. It may affect the range of movement.
Yes.
Right?
Yes.
So
Sir.
these are going to be the complications. Should we call it? I think we've crossed the time. So.
I think we should allow the student. Abhay Dalvi, sir, you want to ask something, sir?
No, I just want to tell the candidate whenever there is any soft tissue swelling, there are three types of complications that can occur. Number one, by pressure in the surrounding structures. Number two, within the swelling, complications can occur. And third is, whenever it is malignant, infiltration is the third complication that can occur. If you remember this classification, it becomes very easy to answer the examiner. I'll repeat again. Complications within the tumor, complications because of pressure outside the tumor, and complications because of infiltration because of the nature of the tumor. If you remember this, it will apply to each and every swelling that you answer. Take it as hydrocele or sebaceous cyst or anything else.
Right.
Okay.
Such a simple way.
Simple. Thank you.
Very good. Very good, sir.
Thank you, sir.
Kanna sir, would you like to give comments? Ratna ma'am, would you like to add something, ma'am?
Yes, sir.
Yes, ma'am.
I wanted it to be discussed that what is she under? Dr. Sahai mentioned wide excision. I would want her to define what are the types of excisions that can be done, that what is marginal and what is radical excision and what is wide excision. Would you be able to answer that?
Yes, ma'am.
Yeah.
In wide excision, we have margin which we maintain.
Just an upfront excision in this particular case should not be an option because there is a thing called sampling error also. So I think the minimum needed is a core needle biopsy, image guided. And thereafter, you should be able to decide the kind of excision that you'll be doing.
Yes, ma'am.
Yeah.
So there's wide local excision, and in this we maintain a certain margin where the tumor is free of the margin in all the planes, both horizontally, vertically, and the deeper plane as well. This is the wide local excision. In terms of marginal excision, the excision. Can you hear? Am I audible, ma'am?
Yeah, you're audible. Clearly audible.
In terms of marginal excision,
so soft tissue
only the capsule. In terms of marginal, only the capsule of the swelling is removed.
So what is the problem if you
there is no
remove the capsule?
Ma'am, there can be pseudocapsule formation around
there
the
are
soft tissue
pseudopods that
sarcoma,
extend into this area. This is called
which
the
can cause
reaction.
recurrence at a later date.
Yes. There can be
Now when we
microscopically
come to
positive margins in this case.
Yes, ma'am. When we come to radical excision, all the surrounding structures which might not also be involved are removed in this.
Yes, and in
like
cases
the
of
muscles
radical may mean compartmental excisions.
Yes,
Yeah.
ma'am.
Thank you, sir.
In this patient, if you are going to excise, are you going to excise the skin also in that?
No, sir. Only the capsule, because we're thinking in terms of benign. With the margin, we're just going to remove
No,
the
no.
capsule.
Let us take it is a liposarcoma.
Yes, sir.
Then you are going to excise the skin also along with that, isn't? And will you be able to close it primarily?
Sir, if we are not able to obtain adequate, like if the tensile strength between the suture line is a lot, we might have to go for revision surgeries, or flaps might be needed. But we would like to go ahead with removal of the skin above the swelling. Sir.
If you are
If
going
it
to
is
remove the
soft
skin which
tissue.
you cannot close primarily, what are the options available to you?
So we can go for flap surgeries,
Which
or
surgery?
we can flap surgery. We can
Flap
use flaps
surgery.
or grafts. Sir.
But can you put a graft here or not?
Sir, sir, we'd like to keep it open in the beginning, and once there is good amount of ulceration from the base of the excised region, we can go ahead with graft. So that is after secondary healing of
Why you
the.
want to keep this open, Jay? On which muscle this is lying?
So this is over the deltoid muscles. Sir.
So are you going to excise the whole of the deltoid in this patient? If it is a
No, sir.
liposarcoma from the subcutaneous.
Sir, we would like to keep 1 or 2 centimeter margin, sir. One minimal of 1 centimeter margin, and we will save the rest of it, sir.
You know, if you are going for, you know, I'm just, it is maybe just a theoretical one. There's a big skin defect is there, then you can, in this area, you can also use the graft also, because underneath the muscle is there.
Yes, sir.
You can simply, because here the movement which is there at the shoulder, you may think that it is at the shoulder, so you cannot put a graft in that area. Like something at the knee joint is there or the ankle joint is there, you cannot put. But here the movement which is there is only the abduction and adduction there.
Yes, sir.
So probably that will be not affected by that. So in this patient, you can get away with a simple graft in this patient, or otherwise
Yes.
you have to go for some rotational flap.
Yes.
Srilaksha.
Yes, sir.
So when you are asked, so better you can use the word, you mentioned wide excision and all. So the aim is to get a R0 resection. Okay. This is when word is expected. Okay.
Yes.
You some lot of disturbances in the chat box. There are few things have been put, you know, marginal.
Yes, sir.
You have actually one excision depth. I am not very sure because, but anyway, it's a benign one. So otherwise, retroperitoneal sarcoma, this problem will come. What is that? You mentioned that large retroperitoneal sarcoma.
Yes, sir.
Yeah.
Sir, sorry, sir, I couldn't hear the question.
The very large retroperitoneal sarcoma.
Yes, sir.
And the principles of this wide excision, what you mentioned, what will happen? When you are trying to.
Sir, if it is very large and we're not able to remove the hole, we can go ahead with debulking surgeries.
No. What I meant to say is that there is a possibility in that you may leave behind that, you know, you mentioned no pseudo capsule and all that thing. So because you may not be able to get to the depth there. Here also shoulder, if you find a nerves, what will you do underneath this? It doesn't spread by perineural tissue unless it is a very highly malignant tumor. You understand, no? So the wide excision principle, you can always have a, you know, it is not a compromise, it is a nurse preservation. You understand what I'm telling?
Yes,
Where
sir.
the
Yes,
tissues
sir.
are available, you can go wide. But when it comes to deeper tissue there,
Yes,
if
sir.
you encounter any nerves or periosteum and all, you can, unless it is a very high grade.
Yes, sir.
Okay, sir. Can somebody mute that?
Thank you. Can I have the last question to her?
Yes, sir.
Hello? Yeah.
Yes, sir.
Tell me, you are
Yes.
a general surgeon and
Yes,
this
sir.
patient comes to you. How many specialities you will involve in treatment of this patient?
Sir, it's a multimodal approach, sir. So,
Yeah.
along with general surgery, I would like to call oncosurgery, plastic surgery, orthopedic surgeon, and the along with that, radiologist, pathologist, a
So what will be,
microbiologist.
1 minute, what will be your action plan as far as the pre-operative discussion is concerned?
So the discussion is held with a pathologist and a radiologist and an oncologist on board, sir. So we're going
That
to
is
have
done.
a session and discuss what is the. Yes, sir.
Patient is scheduled for surgery.
Yes, sir.
What will you discuss as the treating surgeon
Yes,
with
sir.
plastic surgeon, with orthopedic surgeon, with onco surgeon, how we are going to go about it? How does one streamline a complicated procedure? What are the
Yes, sir.
principles
Yes,
of
sir.
treating a complicated procedure which is not in your experience?
Sir, so because we're going ahead with the wide local excision, we'd like to discuss about how to obtain closure for the case because
Correct.
it is a wide swelling. And once the closure
No.
is done,
One
if you would like to go ahead
madam,
with
madam,
chemotherapy or
1 minute. First, you have to plan excision.
Dr. Kanavgal, I think Dr. Ganeshan has to be muted. Yeah.
Yeah. We have to look at how are you planning the excision.
Sir, once the excision is done, we would like to talk about closure, sir.
Correct.
How to obtain closure. And once the surgery is performed, when the patient should be, if the patient should be started on chemotherapy, or if the patient needs, or how many cycles of radio therapy they
No,
need.
that goes beyond surgery. I am
Yes, sir.
asking you pre-operative planning. And what is the concept known as when multiple surgeons who are going to treat this patient come together and discuss not only with among themselves, but also with patient's relatives? What is this concept known as?
So it is a multidisciplinary approach. It's a
How do you go about,
multidisciplinary team, sir.
how do you go about doing it? How will you
Sir,
organize
first,
it?
there is going to be a session which is going to involve all the modalities of doctors necessary, sir. After a
Very
session,
nice.
then there's going to be counseling with the patient and the patient's attender. And the
Correct.
best approach is laid in front of them. And the pros and cons of each procedure is explained. And whichever is more feasible and
Why
the patient's
why
off,
should there
we
be
are
cons?
going to go ahead with
Why should there be cons in this discussion?
that modality. So the patient should know about the complications associated and what are the backdoors, sir. They should be able to choose which is more opt for them. Like, for example, if we're going with radiation, they should also be explained about the post-radiological exposure complications. Or
I'll
if,
tell you, I'll tell you something. You're a very good student, very well read in theory, but unfortunately, you are not looking at the patient. You
the
are telling me
economical
all
aspect,
answers.
so
Your
the
patient,
economical aspect also is,
pardon?
it should be affordable for the patients, sir. A lot of these modalities are very expensive and the patients are not able to afford them.
Let me give you an example. Let me tell
Yes,
you,
sir.
one of the biggest industrialists has come to you with this. Now what?
Yes.
He's ready to pay, he or she is ready to for anything. He can buy you also. Now what? So as a surgeon,
Yes,
economy comes. Every time India tells that economy is the problem with us. No. There are patients who will come to you with all available. Now you have got a team of you as a general surgeon, you have a plastic surgeon, you have a radiologist, you have everybody with you who are ready to. You have a good meeting, decide that this is going to be the plan of action. Are you going to tell the patient that at this point of time, this complication can occur? No, it cannot be done.
Yes,
it is
sir.
a collective responsibility. Remember.
Yes, sir.
Okay. And if you're heading the team, you have to head the team and see that everything goes smoothly.
Yes.
That's
Yes.
the way one goes about. So this multi-modality meeting is one of the important concepts which has come up, I think, in the last 7 years. Everybody should follow it for every
Yes, sir.
procedure, however complicated. Okay.
Yes, sir.
Thank you. Next presentation. God bless.
Thank you. It's not set up.
I think we can go ahead, Kanak Well.
Yes, I think so. We'll call the next person.
Yes, sir. Raghavendra. Unmute yourself, Raghavendra.
Am I audible, sir?
Yeah, very well, ma. Please share your PowerPoint. Can I switch on your video, ma, Raghavendra?
It's on, sir.
Yeah, okay. Good luck to you.
Can I start, sir?
Please, please, please.
Good evening, everyone. Myself, Dr. Raghavendra, second year postgraduate, Department of General Surgery, JIMS Kadar. I'm presenting a case of varicose vein under the guidance of my moderator, Dr. Bharat Kumar Ji Bijinal, sir, Associate Professor, Department of General Surgery, JIMS Kadar, and Head of Department, Dr. Jyoti S. Karegaudar, Professor and HOD, Department of General Surgery, JIMS Kadar. My patient is 18 years male, resident of Gadag, farmer by occupation, presented to the outpatient department with the chief complaints of dilated veins over inner aspect of right leg and lower thigh for the past 5 years, pain in the right lower limb for the past 4 months. History of presenting illness. Patient was apparently all right for the past 5 years. Then, while working, he noticed a dilated veins over inner and frontal aspect of right leg and lower thigh. It was insidious in onset, gradually progressive in nature. Initially, was present over the ankle, which progressed to just above the knee, which increases on walking and decreases on lying down. It was associated with the pain in the leg for the past 4 months, dull aching in nature over calf and lower leg, which was non-radiating, which aggravates on prolonged standing and relieved on taking rest. There is no history of night cramps, no history of trauma, no history of itching or pigmentation of skin or the right leg, no history of bleeding, no history of wound or right leg, no history of prolonged immobilization, no history of abdominal distension, pain abdomen or chronic constipation, no history of fever, no history of swelling in the opposite limb. Coming to the past history, there was no history of similar complaints in the past. There was no history of diabetes mellitus, hypertension, asthma, or TB. There was no history of surgeries in the past. There was no history of any drug intake. Coming to the family history, patient's father had similar complaints since 2 years, and he has not taken any treatment. Personal history, diet is mixed and sleep with adequate sleep and normal appetite. Bowel and bladder movements were normal and regular. He has no high-risk behaviors. To summarize, 18 years male, farmer by occupation with a history of dilated veins over right leg and lower thigh for the past 5 years, which aggravates on walking, reduced on lying down, associated with dull aching type of pain, which was no history suggestive of any complications, no comorbidities with a history of similar complaints in the family. With the history, my provisional diagnosis is right lower limb varicose veins.
Okay.
Without any complications.
Okay, Dr. Raghavendra, let's go back to your first slide.
Yes.
So why do you say this is varicose veins? What are the features in your history?
These are dilated, elongated, tortuous swellings, sir, which are present in over the lower limb, and they are reduced on elevation of the land lying down, sir.
So by your history, could you rule out an arterial disease or a neurological disease of the lower limb?
Sir, based on pain, the intermittent, if the patient complaining of intermittent claudications,
no, let's go back to your history. Okay, let's go to your history of present illness. Okay, so next slide. How have you, by your history, ruled out an arterial disease or a neurological disease? Dilip. Have you or have you?
Sir, I have ruled out, sir.
Let's see, what are the points which you have ruled out for arterial disease?
Sir, in arterial disease, there will be pain which aggravates on elevating the limb, sir. In case of venous.
So have you asked for it? Where is it there in your history? Look, Raghavendra, whenever you get a disease, a vascular disease, the first thing you have to do is establish whether it's a venous, arterial, or a neurological disease. If it's a venous disease, by your history, you have to rule out arterial disease and neurological disease. So if you know what are the characteristics of an arterial disease and what are the characteristics of a neurological disease, you'll have to ask it straight as a direct question, right?
Yes, sir.
And that should come out in your history.
Okay, sir.
Right?
Raghavendra, sir, want to
yes, sir.
Continue, sir.
So please.
Yeah, Raghavendra, what is the age of your patient?
Sir, my patient's age is 18 years, sir.
So what is the duration?
Sir, he has noticed the swelling since 5 years, sir.
So do you, so is it an important thing in your case to look into what is the actual problem going on?
Sir, with the history, since the patient has developed in the young age, sir, it can be a primary varicose vein, sir,
So,
due to maybe valvular incompetence.
so valvular incompetence happens. Saphenofemoral incompetence happens even otherwise also, no? Correct?
Yes, sir.
Yeah. So what other history which you have to take in your patient? Instead of trying to, you have mentioned about all that night cramp, everything I have seen. You have written their progression. So did this patient notice any abdominal wall veins? Number one.
Had no abdominal veins, sir.
Did this patient notice this little bit of, I know these are some of the problems which you encounter later, but any difficulty in walking? Difficulty in walking?
To rule out the syndromes are associated with presence with the varicose veins, sir.
Yes, soft tissue hypertrophy, because
Soft tissue hypertrophy.
younger the patient, all these things should be asked, because instead of trying to ask abdominal pain, constipation, abdominal distension, they have no relevance in this patient. Clear?
Yes, sir.
The next thing you would always ask is a unilateral disease or bilateral disease?
It's a unilateral disease.
Unilateral disease. Why this question? Yes. Why this question?
Sir, in Ehlers-Danlos syndrome, there will be in connective tissue disorders like Ehlers-Danlos syndrome, sir, there will be hypermobility of joints, and in case of crippled.
Yes. So what I'm trying to tell you, the obstruction can be little higher up. So when you have a problems in the inferior vena cava, etc., Burchiari, etc. So problem can be bilateral disease. Abdominal wall veins also you should inquire in a patient who has got. See, this boy is just 18-year-old and his problem is since 5 years, correct?
Yes, sir.
What is his occupation, you said?
Sir, he was a student, sir. He left education and since 2 years, sir. So he's doing he's a farmer, sir, now.
Now farmer, but probably what is the reason why he left his education? Is it related to the veins related issue or something else?
No, sir, to support his family, sir.
Okay, anyway, these are different issues. So in a case like this, you have to think of more of a congenital issues here. Yes, clipper tunnel, you mentioned about that. So unilateral disease or bilateral disease. You also should mention medial veins or lateral veins or posterior veins, means veins behind. Veins behind. Veins on the outer aspect, veins on the inner aspect. To get an idea about long saphenous we are dealing with, or short saphenous, or popliteal. Okay. You asked about no history of fever. Just change the slide once. Slide, next slide. So that here. So big list is there. So all this, see, prolonged immobilization, all this relevant when you have one who is not working at all. You are studying with the active student and now is doing a farmer, correct?
Yes, sir.
So in this patient, all these are not itching, yes, definitely. Pigmentation, yes. Fever, what is the relevance of this fever question?
Sir, fever is observed if the patient has developed a thrombophlebitis, sir, superficial thrombophlebitis.
Oh, shit.
Superficial?
Thrombophlebitis, sir.
Superficial thrombophlebitis. Yes. What is the swellings in the opposite limb?
Sir, if you have to rule out the varicose vein in the opposite limb, sir.
So for varicose vein at a PG level, you can always tell dilated veins. You don't have to too much worry about that patient's own words like that. Okay. You can even mention ulcer. There's not an issue. So basically, younger the patient, you should think of a probable congenital etiology. He's just 13 and 5 years he's been having this issue, correct?
Yes, sir.
Okay. So, sir, these are my questions.
Sir, Professor Abhay Dalvi sir is raised his hand. Sir, any questions from your side, sir?
Yes, I have some question.
Yes, sir. Please go ahead.
Unilateral dilated tortuous elongated vein starting at 13 years of age, and he's at 18. Apart from varicose veins, what else does come to your mind? And what history will you ask?
Sir, syndromes like if the
You
patient
are
has
going into syndromes. 1 minute. You are going into syndromes and you are forcing me to ask you about these syndromes. Don't do that. Congenital condition, relevant question I will tell you, which I will ask this patient is there any increase in size of the limb? If he says yes, what does it tell you? This is even before examination. Patient says my left limb has increased in girth and there is dilated tortuous. Yeah, go ahead. Go ahead. You are giving correct answer. Go ahead.
Sir, we should rule out the elephantiasis, sir.
Elephantiasis, my dear, it has nothing to do with varicose veins. When will the veins dilate, become elongated and tortuous? Because of valvular incompetence, that is number one. And number two, if blood comes into the venous system, when it should not come, what is that condition?
AV fistula, sir.
Yes, then that is more important, no? Such a young age patient comes to you with varicose veins. That is the first thing that you are talking of syndromes, because you have read last night all about all these syndromes. It doesn't work that way in clinical practice. It doesn't work. Yes. When you started presentation, the first thing that I came to my mind because of the age of the patient was whether this patient has an AV fistula. Because otherwise it is not fitting into common causes. Anyway, go ahead. Go ahead, complete the presentation.
Shall I continue with
Yes,
general
please,
physical examination?
Please.
Coming to the general physical examination, patient was examined in adequate light with informed consent after exposing below the umbilicus. Patient was conscious, oriented to time, place, and person. He was moderately built and nourished. His height was 175 centimeter, weight 70 kg, with BMI 22.8 kg per meter square. His blood pressure was 124 over 70 millimeter of mercury, measured in right brachial artery in supine position. Pulse rate was 84 beats per minute, with regular rhythm and good volume. Respiratory rate was 16 cycles per minute. He was afebrile to touch. He had no pallor, icterus, clubbing, cyanosis, or pedal edema or lymphadenopathy. This is the clinical picture of the case, sir. Local examination, gait was normal. Right lower limb, there was a dilated, elongated tortuous vein along the anterior and medial aspect of the right lower limb, which was extending from medial malleolus up to 5 centimeter above the knee. Blowouts were noted in the medial aspect of mid-thigh, which was approximately 20 centimeter above the knee. On elevation of the limb, dilated veins were reduced. There was no swelling noted over the back of the leg. There was no skin discoloration, edema, scarring, or ulceration. There was no loss of hair, and Morris's test was negative. Left lower limb was normal. On palpation, there was no local rise of temperature. Modified Perthes test was negative. Brody Tenderbeck test. In part 1, there was rapid filling noted from above downwards, and the part 2, gradual filling of veins below upwards. On multiple tourniquet test, perforator incompetence is noted at below knee and lower leg. And on Fagan's test, the pits felt at 5 centimeter and 12 centimeter from the medial malleolus. On percussion, Short's test was negative. Auscultation, there was no bruit heard. Arterial pulsations of bilateral lower limb was normal, and joint movements and sensory system of normal. Systemic examination, respiratory system, bilateral normal vesicular breath sounds heard, no added sounds. On CVS, S1, S2 heard and no murmurs. CNS, no focal neurological deficit noted. And per abdomen, soft, non-tender, and there was no organomegaly. Final diagnosis, primary varicose vein involving right great saphenous vein with saphenofemoral junction and below knee and lower leg perforator incompetence without any evidence of DVT. My CEAP classification is C2S, EP, ASP, and PR.
So nobody is asking you a question, so I will ask you a question.
Yeah. Good, sir,
What is
please.
the importance of Brody-Trendelenburg's test in varicose veins?
The Brody-Trendelenburg test is done to identify the safety incompetence and perforator incompetence, sir.
Correct. How you get it into two parts?
Sir, and first, the patient will be from standing. We should make the patient lie in supine position and elevate the limb, and we'll empty the vein, sir. And just below the saphenofemoral junction, we'll tie the tourniquet, and we should ask the patient to stand. And after removing the tourniquet, if there is a sudden filling,
Which one?
rapid filling of
Which one will you remove first? The lower one or the upper one?
sir, for in multiple tourniquet test, we will
No. Don't divert the issue. I am on Brody-Trendelenburg test.
yes, sir.
Don't go on to multiple tourniquet. I am on Brody-Trendelenburg.
Sir, in first, sir, we will remove the tourniquet, sir.
Which one? Upper one or the lower one?
Sir, in only
You
one
just
tourniquet
said
will be
no, rapid filling from above to below. Which one will you remove first?
below. You will be removed first, sir.
Are you sure?
Sir, in Brody-Trendelenburg test, above should be removed, sir.
So say
Only
that.
one tourniquet.
So the first part of Brody-Trendelenburg is to know whether SF junction is incompetent. So you remove the upper one first. Once you know that that is competent or incompetent, then you go to the perforators.
Yes, sir.
In that, I want to then ask you, when did Brody describe this test and Trendelenburg describe this test? These are higher level questions because answering well.
I don't know, sir.
Okay, at least tell me the first name of Brody and first name of Trendelenburg. I'll give you the answer. It's Benjamin Brody and Frederick Trendelenburg. I'll take you a little lateral out of this. What other things are given credit to Trendelenburg for?
Trendelenburg positions are there, sir. Trendelenburg
Yes.
and reverse Trendelenburg. And the procedures are Trendelenburg operations.
Very
and
good.
Trendelenburg gate is there, sir.
Very nice. I'm not going to get into details of this. Anything Trendelenburg has described as far as larynx is concerned? If you don't know, quickly say, I don't know. Let's go ahead. Doesn't matter. So you have done this test and you found that SF junction is incompetent and perforators are also incompetent. Correct?
Yes, sir. Yes, sir.
Why do you require other tests? Which of all the other tests that you have done will be the most important test as far as you are concerned? Deciding
Modified
that.
test.
Pardon?
Modified test is important one, sir.
Very good. Why?
Sir, first we have to rule out the deep vein thrombosis, sir.
Very good.
For that,
So
we need to do.
Gives you evidence of deep vein thrombosis. Correct?
Yes, sir.
Yes, very nice. I think the other examiners can take over from here.
Dr. Rakha, you mentioned it as primary varicose vein. Why do you say so?
Yes, sir. Sir, on his patient is a young age, sir, and there was no history suggestive of any obstruction, sir.
What are the types of varicose veins?
Sorry, sir.
Types of varicose veins? Primary?
Sir, congenital, primary, secondary varicose veins.
Why congenital? What is the cause of congenital varicosities? It is very rare, extremely rare.
Yes,
what is the reason? Said to be absence of valves. Congenital.
Hypoplasia, aplasia of the valves.
Of the valves. Then primary. Then what else?
Secondary.
Secondary. Obviously secondary. So what are the causes of secondary varicosities?
Secondary varicosities may be due to deep vein thrombosis, sir, or obstruction
Okay.
of the obstruction of the vein, maybe pelvic tumors or any abdominal lymphadenopathy.
Post-thrombotic destruction of valves. Okay. Then
And
physiological.
in case of female, you can consider pregnancy, sir.
Yes, very common. Then all the pelvic swellings
Pelvic tumors,
like fibroids, ovarian cysts, large abdominal lymph nodes, pelvic tumors, retroperitoneal fibrosis. There are the list is large in terms of secondary varicosities, isn't it?
Yes.
What is the incidence of varicose veins with respect to male sex, female sex?
Sir, it is more common in male, female in the ratio of 10:1, sir.
10:1.
Sir.
10:1, is it? Not 10:1 actually. Up to 30% in women and 15% in men. Okay. So which side is more affected? It's a very basic question. Which side is more affected with varicosities in terms of incidence again of both sexes?
Sir, in left side it's common, sir.
Any theories, any proposals as to the cause for the common incidence on the left side?
Sir, left iliac vein is compression is more common, sir. Left iliac compressed by the right common iliac artery.
That is a very rare scenario. What is the name of that? That is Mertner's.
Mertner's syndrome, sir.
Yeah. But that is a very rare condition. Even otherwise, the left side, the number of veins are more, said to be more. That is a proposal. And the location of chambers and pumping mechanism of heart also favors more supply to the left side. There is also another proposal. So anyhow, the number of veins are more on the left side. So left lower limb is more frequently affected. Okay.
Yeah, I will come in here. You have talked of CEAP classification, and you have given some big thing which looks like some password. Can you explain that?
Sir, CAP classification is clinical classification, etiological classification, anatomical and pathological, sir. In C, in my case, C2, yes, sir. That is varicose veins with symptoms, and etiological classification is primary, and in anatomical classification there is involvement of superficial and perforator, and pathological is due to reflux. Sir.
Very good. Now, why is this 2S there?
So patient is
C2?
having symptoms.
So what were the symptoms? I must have lost on your presentation. What were the symptoms you said?
Pain, sir.
Pain. What was the type of pain that you get in varicose veins?
Sir, dull-aching type of pain can be seen, sir.
When does it occur?
Sir, it is usually occurs in the end of the day, sir, usually in the evening.
So if I am resting at home whole day, still I will get pain in the evening?
On long standing, it will be there, sir.
Pardon?
On long standing,
so
after activity and long standing, the patient will be having the more pains.
Correct. So when there is work of calf and the leg muscles, this is what starts happening. Why does it occur?
Sir, due to activity, there will be stagnation of blood in the superficial venous system, sir.
Correct.
And there will be release of fibrins, and which causes the hypoxia and leads to pain, sir.
See, look. I asked you a very simple question. Now you are getting into release of fibrins, etc., which is now prompting me to ask you more questions. Don't do that. Answer to the point. Work leads to stagnation. Stagnation leads to pain. It's as simple answer as that. Now you elaborate on all these theories of fibrin, etc., etc. to me.
Sir, it is a fibrin cuff theory, sir, where there will be after stagnation of blood, there will be release of the blood cells, and there will be fibrins will be released. There will be cuff formed around the perivascular region, and this causes the hypoxia and leads to pain, sir.
Very good. Now tell me,
And
if this keeps on continuing, what is going to happen and where?
there will be hemostasis and there will be pigmentation,
Okay,
and the patient will be having the itching, sir. And
correct.
and there can be eczema and
Okay.
lipodermatosclerosis, and
No,
even
no.
patient can
That
probably.
comes in much later. When 1 minute. You started with pigmentation, you started with itching, you reached eczema. Then what happens?
And ulceration, sir.
Ulceration occurs. Once ulceration occurs, what else can happen?
There will be Palipus equinus can
That comes
due to
last.
fibrosis, sir.
That comes in last, my dear. How many patients of ulcerations due to varicose veins you have seen with equinovirus? Before that, many complications can occur. You started with superficial thrombophlebitis. Can it not occur after ulcer starts?
Can occur, sir.
You think superficial thrombophlebitis just comes like this in varicose veins? No. In case superficial thrombophlebitis occurs in varicose veins, what will you do and investigate this patient, and for what?
Sir, we should check for the thrombosis, sir, and Doppler should be done for the patient.
No. All your investigations for DVT are normal. Patient suddenly develops a varicose vein superficial thrombophlebitis. What other dangerous conditions that you will try and investigate this patient for?
Should rule out the pulmonary embolism.
Malignancies, my dear, forget about it. Forget. They are malignancies. Forget about it. So ulceration has occurred. What next can occur in this patient?
Yes, sir. Migratory thrombophlebitis like it.
That is fine. Done. Next.
Varicose ulcer, sir. Then lipodermatosclerosis, sir. Their contracture.
That is again late. What immediate complications can occur which will require emergency treatment?
Bleeding, sir.
Bleeding. What do you do if the patient of varicose veins starts bleeding on the road?
Sir, we should first elevate the limb and give pressure.
Very good. Very nice. Very nice. Can calcification occur?
Yes, sir.
Correct. Then fibrosis starts occurring. Then all your joint complications come into picture. Okay. And what is the last complication which is there in literature, which is very rarely seen?
Sir, thromboembolism is less than 5.5%.
See, you are so stuck with theory. I'm asking you a long-term complication of varicose ulcer.
It's marginal ulcer can.
Marginal ulcer. So you hear the question from an examiner properly, then only you can give proper answer. But because you have read theory and you want to give me some exotic answers, you are getting into it. So what was your exotic answer? You talked about some answer.
Pulmonary embolism. So pulmonary embolism.
When should pulmonary embolism occur in a patient of varicose veins with patent deep veins? And how? Give me the pathophysiology of this.
It is an endothelial injury, sir.
That is always there. There has to be thrombus, which has to go through these varicose veins into the deep veins and then go into the pulmonary circulation. How frequent you think it is?
More less than 0.5%.
Then why do you answer this? So don't try to show your theoretical knowledge. Let's come to practical aspects. Okay? Practical aspects. You have got a patient. What is your final diagnosis?
So primary varicose vein involving right great saphenous vein, sir, with saphenofemoral junction and below and lower leg perforator incompetence.
Very
without
good.
any evidence of DVT.
Correct. And Doppler has proved it.
Yes.
What will you do for this patient?
Sir, after Doppler, since the I will go with the open surgery, sir. Like
Yeah, go ahead.
Trendelenburg operation, sir.
What is Trendelenburg's operation?
Trendelenburg surgery is flush.
You forgot to mention when I asked you about Trendelenburg. Go ahead.
It is juxtafemoral flush ligation with stripping of veins.
Have you seen or done this operation before?
No, sir.
No, sir. Then let's go to theory because you're so good in theory. There are three vessels or veins which you ligate before going on to ligate flush ligation. Which are these veins?
Sir, superficial circumflex iliac vein, sir, and
Correct.
superficial inferior epigastric vein, and
Very good.
superficial external pudendal veins.
Very good. Where do these originate from? Or which one of them? 1 minute, listen. Which one of them you locate on the anterior abdominal wall in routine pelvic surgery?
Superficial
2 out of 3.
inferior epigastric veins.
Superficial?
Inferior epigastric veins.
That is one. Second one?
Circumflex iliac, sir.
Then where does the pudendal come from? Where is
Medial,
this
sir.
located in the pelvis? And which operation it can give you trouble? See, my concept of you're doing very well. Let me congratulate you for that. But when you start talking theoretically in a practical examination, it can get you into deep trouble. Now tell me which vein comes in between superficial inferior epigastric vein and circumflex vein on the abdominal wall in the left iliac fossa, which can be dangerous to any laparoscopic surgeon when performing. Pardon?
In corona mortis, where the
So I'm not talking of corona.
obturator.
I'm talking of 1 minute. I'm talking of abdominal wall in the lower abdomen. You said circumflex iliac comes and superficial inferior epigastric comes. There is one more.
Inferior epigastric arteries.
Very good. Now, what is the distance between the three? Normally?
I don't know, sir. Exact distance, I don't know.
Okay. Study it. It is important. Yes. I am a laparoscopic surgeon, so I know what is the importance of knowing where the locations of these vessels are. Let's go back to varicose veins. How will you convince this patient that he requires treatment?
Sir, first I will inform the patient about the condition and the complication he can get in the future on long-standing, sir.
Very good. He said, I will not stand. Will sit. I am your patient. You are asking me questions, convincing me for some intervention that you want to do.
I will give the option of treatments available for the patient for the varicose vein, sir, and the complications associated with them, and which are
the complications. You have told me complications. You have told me that it is because of long standing that I do. I say, okay, from tomorrow I will sit at home. Now what?
Even if the patient the patient is sit for this long time also, it can cause DVT, sir. I will explain that also.
Why should? If I'm sitting in a proper position, why should it increase? It marginally will increase, but the period of complications is going to take a lot of time.
I will explain about the non-surgical treatment available for the patient, sir.
So let me know
Compression
what
stocking.
other options that you can give me.
Like compression stocking for sir.
Very good.
And medical management, medical management drugs which are available for the patients.
One minute. See, when you say compression dressing comes up to where? Is it below the saphenofemoral junction or no?
Below the saphenofemoral junction.
Correct. My main saphenofemoral is at fault. Correct or no?
Yes, sir.
So you have to tell me that this is the main junction which is at fault, and little bit here and there you are going to have complications. It is as simple as that. If it was only perforated incompetence and no SF junction incompetence, conservative treatment still can be given. But this is a major valve,
yes, sir,
which is not functioning properly. So this is what you will have to actually communicate with the patient. And that's why in varicose veins, all these tests and Doppler become very important before advising the patient of any intervention. Okay?
Yes, sir.
Yeah, I just request some other people to get into this now.
Dr. Raghavendra, can we go back to the image, please? Can we go back to the image?
Thank you, Ratna.
I've been listening to your good questions. Yeah. So these are very prominent varicosities that are truncal varicosities. First tell me, why are they tortuous? Why are they tortuous?
They are elongated, ma'am, and due to long.
So because whenever any elongation happens between two fixed points, it tends to become tortuous. No, these are huge veins. Did you look for pulsatility in them? Did you mention anywhere in your examination if you palpated them for
yes,
pulsatility?
There was no pulsatility.
Huh?
Did
you mention it in your examination finding?
Pulsatility, I have not mentioned.
Do you think it is important? If I came across a patient with such prominent veins, I would want to auscultate and rule out, because veins can get arterialized also by an AV fistula. And he's a young boy. You have to think of congenital anomalies, right? Have you taken the length of the limb?
Length of the limb was normal, ma'am.
How do you know it is normal? You've not talked about the gait. You've not told us about the length of the limb. Did you auscultate along the prominent veins? Huh?
Yes, ma'am. I have asked. Auscultation, no bruit was had.
What did you auscultate for?
For bruit, ma'am, which can be seen in AV
bruit
fistulas.
Will be seen in arteriovenous fistulas, and sometimes in large varicosities. You may also find a venous hum. Right? You told us about the three venous tributaries that are ligated. Can you tell us any artery that is ligated in varicose vein surgery? So you only said that you have to ligate at the saphenofemoral junction. So to be able to see the foramen ovale, you have to ligate the inferior pudendal artery at the lower border. That's the only pulsatile structure which is ligated in this surgery. And it shows you the trijunction at the level of saphenofemoral junction. Then only you proceed further, right?
Yes.
You said Trendelenburg operation is ligation at saphenofemoral junction after ligating the tributaries and stripping. So stripping is a separate operation. Trendelenburg is only the upper part, the first part of it.
Yes.
Yeah, these are a few points I wanted to highlight. How do you look for the sites of perforators clinically?
Ma'am, there will be blowouts, and then emptying the vein, we can feel for the pits, ma'am, like crescent shaped pits can be seen on the
These are
perforators.
these are the defects in which part of which anatomical
Deep fascia,
region?
ma'am. Defects in the deep fascia.
These are very good. These are defects. And what is ankle flare?
Ankle flare is the intradermal venules, ma'am. Fan-shaped intradermal venules are known as ankle flare.
Any other name for them? They are present around the ankle, around the medial
Malleolar flare,
malleolus.
ma'am.
Yeah. So can you get white patches also on the skin?
Yes, ma'am. In lipodermatosclerosis, we can see the white patches, ma'am. And atrophia blancae.
Atrophy blanche is there, yeah. So these are the white patches that you would come across. So where exactly would you, is there any communicating vein between the short saphenous and the long saphenous?
Yes, ma'am.
Are they two separate systems or do they communicate also?
Communicating veins are separate from direct perforators.
No, no. What I'm wanting to ask you is, are short saphenous and long saphenous two different watertight compartments, or do they communicate also?
They communicate, ma'am, with the Giacometti vein.
Yes. Very good. So, any other operative procedure? How do you identify perforators on the table?
We can feel for the defects, ma'am.
Yeah.
But
So how do you know that what you're pulling out is not just a varicosity and it's a perforator? So you look for T junctions. And the vein which is going beneath the deep fascia is the perforator. At the T junction has to be identified for you to know what you're ligating is a perforator. So,
Raghavan, these perforators which are there in the leg, are they on the great saphenous vein?
Sorry, sir.
The perforators which are there on the medial side of the leg, where are they situated?
They are situated between the deep vein and the superficial venous system, sir, in the deep fascia.
No, but are they along the great saphenous vein?
They are perpendicular to the vein.
No, they are on a branch which is there of the great saphenous vein. Do you know which branch is that? They are not on the main. They are not on the main GSV.
Yes, sir.
They are on the posterior arch vein. That is called as posterior arch vein. Okay, so the main perforators which are there, which you look at 5, 10, 15 centimeter from the malleolus, they are at the posterior arch vein. Now tell what are the SEEP classification which you have told. Is it a new one or it's the old one?
New one, sir.
Okay. So what are the changes which has been made in the new classification?
Sir, in 2020, the new modifications done were along with the varicose veins, recurrent varicose vein C2R is added.
Good.
And C4C is added, which is corona phlebitictia. And C6R for recurrent varicose ulcers.
Right. And what is there in the change in the E? CEAP. What is the change in the E?
Reflux and obstruction are both.
No, that was there before. Something like in extravenous and intravenous.
I don't know, sir.
Okay. You know any syndromes which are there?
Yes, sir. Triple tenor syndrome, sir. May-Turner syndrome.
Yes. What is
And
May-Turner?
Parkes-Weber syndrome, sir.
What is May-Thurner?
May-Thurner syndrome is compression of left common iliac vein by right external right common iliac artery, sir.
Yes. So that goes into the E1. It is the extrinsic type of that. Like if there is a thrombus is there, it is intrinsic. But this is extrinsic pressure which is there. What is the change in the A? What is the change in the A?
Anatomy.
Yeah. So what is the change?
Superficial and perforator, sir.
Yes, it was there, but what is the change? Now you have to write down the full name of that. So you have to write down, initially the numbers were given for that. But now you have to write down the full name. That it is a GSV below knee or it's the GSV above knee. Okay. Any change in the P? There is no change in the P. Okay, so there is only change in the CEA in the recent classification. Okay, if you're doing a Doppler for this, so you are doing only the Doppler or you want to do a duplex?
Duplex is preferred, sir.
What is duplex?
Duplex is ultrasound consists of a B mode and the Doppler mode, sir.
So what does the Doppler looks and what does the ultrasound looks?
Doppler looks the velocity and flow of the blood column in the vein, and the B mode is the anatomical delineation of the vessels, sir.
Okay, and if you want to see the volume of the blood, which investigation you will do?
Plethysmography.
You do plethysmography, good.
Yes.
Now in the duplex scan, when you say it is a saphenofemoral incompetence is there.
In duplex scan, when there is a reflux of more than 0.5 seconds, sir, it is considered as a saphenofemoral incompetence.
And when you say the perforator is incompetent?
Perforator incompetence when there is a defect more than 3.5 mm and there is a reflux of more than 1 second.
No, not 1 second. No?
0.5.
Again, yeah, some people say it is 0.35, some people say it is 0.5. Okay, so 3.5 millimeter diameter with either 0.35 or 0.5 reflux is there. Now, if you have to see one thing on color Doppler, you are given a choice that you have to see only just one thing. Which one you will like to see?
Sir, thrombus scan we should see, sir.
You want to see the deep vein thrombosis. What is
Deep
the
vein
status
thrombosis.
of the deep vein thrombosis?
Deep vein thrombosis.
Now, ideally, if you have to carry out the duplex scan for a patient, what is the position of the patient?
Patient should be on standing position with the weight bearing on the opposite limb, sir. And limb is externally rotated at the hip and mild flexion and at the hip and knees.
Okay, good. Now, where do you see the great saphenous vein? How does it look like?
On Doppler, sir, there will be Mickey Mouse sign can be seen.
Mickey Mouse. What is that Mickey Mouse sign?
This is the consist of common femoral vein and artery, medially saphenofemoral vein.
So what is that Mickey Mouse? What are the things which make the Mickey Mouse?
Common femoral artery and great saphenous vein and superficial femoral veins.
Okay. Now, what is Egyptian eye? What is Egyptian eye?
Egyptian eye is it's a seen. It is measured in the plethysmography, sir. It is the
No, it is in
amount
the
of
duplex. In the duplex, not in the plethysmography. In the duplex.
It is the amount of blood. It is the volume of blood present after the tiptoe maneuver.
In fact, this is when you do the transfer scan over the ultrasound, then you see the great saphenous vein in between the two fascia.
subfacial saphenous
In between the two fascia, you will see one black spot there. And that is called the Egyptian eye. You know?
Yes,
okay.
Can I come in here?
Yeah, please. Please.
Yeah. Looking at these two limbs, because I have not seen this image, I'm sorry. I still feel this is a AV fistula.
Yes.
You said there are no signs of AV fistula. Which investigation will tell you that this is a AV fistula?
Sir, an ultrasound is, you can see, sir.
Ultrasound or Doppler?
Doppler, sir.
Now you talked of Mickey Mouse sign, and sir asked you about Mickey Mouse sign. Because you are answering well and well read in theory as I see you, who is Mickey? Who is Mouse? Where do they come from? Florida or Los Angeles? This is for distinction answers. Huh? Don't take them as trying to pull you down, please.
Yes, sir.
See, when you
Florida.
talk of such signs, you should know where these people come from and how do they look like and how it is adapted to your signs. Just for your sake, you're a good student and you have to know. In case you want to utter these sort of nomenclatures, you have to know. Okay? So read about them. Now, I am telling you that this is likely to be more of AV fistula, and you are saying this is varicose veins because of only saphenofemoral and perforated incompetence. Why should these varicose veins become that big, especially above the knee? Unless there is constant pressure on these veins. Either there has to be deep vein thrombosis, or there has to be a communication with the artery. You agree with this?
Yes, sir.
Correct. Now, all your tests that you have done, there is negative DVT. Forget investigation.
Yes,
Moment you do modified Perthes test and you know that there is no evidence of DVT and still such a big limb, and I believe you said something about elephantiasis during our discussion.
Yes, sir.
The next thing I think at this age that should come to your mind that there is some arterial communication. So you will have to be very careful in treating this patient because the only thing this patient possibly initially requires is disconnection. So tell me, with a diagnosis of AV fistula leading to these sort of varicose veins, what are the investigations apart from Doppler? Doppler is not very sure.
Yes.
It says maybe there is arterial communication. What other investigation will you do?
Sir, angiography should be done, sir.
There are many angiographies which are described today. There is angiography, digital angiography, CT angiography, MR angiography.
MR angiography is preferred.
Why? Why not CT? See, this is what happens in an examination when you are taken a little by the side.
Yes.
I am coming in with these questions only to see that you develop yourself well. When you read so much, you got to know all these things also because this sort of cases are rare. It's a difficult case.
Yes.
So please read about it. You have done an investigation and it shows you that there is a arteriovenous communication. What is the next treatment that you'll do? There is communication between artery and the vein, which is giving rise to these problems. You have to block it, no?
So ligation of the connection fistula.
If I as a patient say, is there any other modality where this thing communication can be blocked?
Sclerotherapy.
You will do it? or someone else will do it. And
Intermission radiation.
sclerotherapy is not a correct answer anyway.
Embolization.
Very good. Embolization can be done, which will correct most of the problems, but still the veins must have lost their smooth muscle and they may require further treatment. That's a thing of the future.
Okay.
But I think I agree with Dr. Ratna that this limb doesn't look good. There is something wrong with this limb. It's not only saphenofemoral incompetence. I'll give it to the other examiners. But you have done well. You are well read and this, but only apply your knowledge to your case. That's all.
Yes.
Again, if you think it is because of arteriovenous fistula, what will be the clinical signs? What will be the clinical signs of the arteriovenous fistula?
Sir, there will be pulsatile swelling. There will be pulsatile, sir.
Yes.
And we can hear the bruit over the swelling, sir.
You hear a bruit over the arteriovenous fistula or something else? On a arteriovenous fistula, do you hear a bruit or something
Venous
else?
hum. Venous hum.
Not venous. What is that called as? If it is arteriovenous fistula?
Branham.
It is machinery murmur.
Machinery murmur.
Okay. So you feel and also hear the machinery murmur over there.
Machinery murmurs.
What is the Branham sign? The arteriovenous fistula?
Sir, sir, I don't know.
Okay, when you press the arteriovenous fistula, there is a change in the pulse rate is there. Okay.
Yes.
What happens to the limbs of a arteriovenous fistula? What is that called as?
Limb lengthening, sir.
Macro?
Local gigantism.
Yes. Gigantism may be there. Now, these arteriovenous fistula, they go inside the bones also, inside the medulla of that.
Yes.
Now, if somebody has got a similar picture in the upper limb is there, and he says that I have undergone some surgery, what it can be?
Lymphedema, sir.
No, this type of the limb in the upper limb, and patient says that I have undergone some surgery. Can it be iatrogenic?
Yes.
Patient with a renal failure, what you will do?
AV fistula will for dialysis purpose.
So you are making it fistula, na?
Yes,
you
sir.
are making AV fistula in a case for the dialysis purpose.
Dialysis patient.
Okay, so the similar type of the veins, the pulsatile veins may be there in the, especially it's not made in the lower limb usually, it's made in the upper limb. That's what I said, upper limb. Okay. Now, if you think it is a patient with a saphenofemoral incompetence only or perforator incompetence, but I think it is right that probably something else is there in this patient. What are the various options available to you?
Sir, it can be surgical.
Yes.
Or non-thermal, non-tumescent endovenous laser ablation, radio frequency ablation, and foam sclerotherapy, sir.
Yes.
For perforator, steps can be done, sir. And high intensity focus ultrasound beam, HIFU treatment is there, sir.
Is SEPS now done nowadays?
It's not done, sir.
What is SEPS?
Superficial endoscopic perforator surgeries. Superficial endoscopic perforator surgeries.
Okay. SEPS has become almost obsolete now. but you can do the other types of the
private
treatments, and basically you can divide your treatments to the tumescent variety and the non-tumescent variety. So what are the things you can do in the tumescent variety?
Endovenous laser ablation and radio frequency ablation, sir. In
When you're doing the
non-tumescent,
laser ablation, do you know which laser is used? What is the type of the laser which is usually used for the EVLT?
Nd:YAG laser, sir.
No, Nd:YAG is not used for this purpose. Nd:YAG is also used for the, like the reticular veins are there, small veins which are there, or telangiectasia is there, then you can use the Nd:YAG for that. But for this one, you are using the?
Holmium.
No, it's the diode laser. Okay, it is a diode laser which is used, and diode laser comes into different frequencies. You know which is the commonest frequency which is used for that, which can also be used for the proctology purpose also.
Wavelength of 1470.
Yeah, 1470, you know? 1470 is the, you know, this particular type of the diode laser which is used. What are the other places where it can be used apart from the varicose veins?
Sir, in case of for hair removal also it is used, sir.
For hair removal, again, it is not the good one for the hair removal. Hair removal, you can go with the Nd:YAG. Okay, you can go for the liposuction for this. Okay, so first is the varicose veins, second is the proctology, especially the benign proctology. Fissure, fistula, hemorrhoids, spinonidal sinus. Okay, it can be used for liposuction. It can be used for the cosmetic surgery of the external genitalia females.
Yes.
Okay, so these are the few other areas where this type of the diode laser can be used.
Yes.
So when you're doing the diode laser, you know what precaution has to be taken when you're putting the probe into the vein?
Sir, only short segment should be given, sir.
Now, which area of the vein you burn?
90%.
Usually, which area of the vein you burn? In the thigh or in the leg?
Thigh, sir.
In the thigh. Huh? Why not in the leg?
It runs along with the nerve, sir.
Yes. Which nerve?
And it can lateral burns can cause injury to the nerves.
No, no. Which nerve is there along with the GSV?
Saphenous nerve, sir.
Saphenous nerve is there. Okay. So usually it is done in the thigh. And what is the precaution from the saphenofemoral junction?
It should be given at least 5 centimeter distal to the saphenofemoral junction, sir.
Not 5 centimeters is too big. At least 2 centimeters. At least 2 centimeters from the saphenofemoral junction. But some people also do what is called the cryo laser, where they go, no, not the cryo laser, crossectomy. Okay, you can do a crossectomy just like you are doing a flush ligation of the saphenofemoral junction. Similarly, you can do the laser crossectomy for that. But that is, you know, very few centers they do. But ideally, you should keep at least 2 centimeters from the saphenofemoral junction. Why you keep 2 centimeters?
It can cause skin necrosis, sir. And it can also cause the recurrence of the varicose veins, sir. Neovascularization and
no, that is what is called the E-hit. You know what is E-hit?
Sir. And heat-induced thrombosis. Heat-induced thrombosis.
Heat-induced thrombosis. Okay. When you are using the, you know, you can use a glue also.
Cyanoacrylate can be used. Yeah. Trivex.
So what precaution has to be taken then in the if you are using the glue? How far from the saphenofemoral junction? That should be at least 5 centimeters.
5 centimeters.
Okay. Because once the glue it goes into the femoral vein, it is very difficult to tackle that. Okay, so that should be at least 5 centimeters. So basically, you can divide into the tumescent variety and the non-tumescent variety. In the tumescent variety, you can use a laser, you can use the radio frequency ablation, you can use a microwave, or you can use a steam. So these are 4 options which are there. And for the non-tumescent variety, it is a glue. What else?
Foam sclerotherapy, sir.
Foam sclerotherapy. And third one is a combination of the two things. What is called a MOCA.
Mechanochemical ablation.
Yes, mechanico-chemical ablation.
MOCA.
So when you are giving the patient the sclerotherapy, do you give the liquid or do you give the foam?
Foam, sir. Foam is preferred.
Okay. And how do you make that? Any method for making that foam?
Tessari technique is used, sir.
Tessari technique. What is that Tessari technique?
We'll combine one part of sclerosant to 3 part of air, and which is oscillated for 10 to 20 times, sir. And
how do you mix them? How do you mix them?
Sir, connecting the 2 syringes in 3-way.
Okay, so 3-way and the 2 syringes. You know? And to make a foam, how many passes has to be done?
10 to 20 oscillations should be done.
At least 20 passes. You know? Then you can get a good foam gel. Okay.
I'll just come in here. Define full form of laser. Are you hearing me?
Yes, sir.
Define laser. I'm asking you this basic question because you all are hooked on to short forms. And you know everything about lasers. Yeah.
Sir, light amplified
amplification.
I don't
Then
light application stimulated emission of radiation.
Very good. So how many types of lasers do you know?
Types of lasers.
Yes, of course. And each one of them has applications. So if there's a patient of GI bleed and you want to apply laser to stop that, which laser do you use? I'm just taking you away from your case because you have read so much about your case. Pardon?
India lasers.
Are you sure? Or you're taking a chance? Be very frank. You have done well.
I'm not
now
sure.
About this is about gold medal.
I'm not sure about this, sir.
Okay. So whenever treatment options in any disease that you are treating, laser comes into picture, any examiner can take you away when you utter. You talked about cyanoacrylate, right?
Yes, sir.
Glue.
Yes, sir.
Do you know what is the combination of cyanoacrylate that is used in actually stopping the flow?
Butyl N2 cyanoacrylate.
Pardon?
Butyl N2.
Butyl is only one component of it. There is another one. There are 2 components of acrylates which are used.
I don't know.
Doesn't matter. Go back and read.
Yes, sir.
Not an issue at all. Okay? Not an issue. Now, of all the treatments that you have enumerated for treatment of these veins,
yes,
which is likely to be most successful? Considering, let me finish. Considering that this is not a AV fistula.
So
You think
intravenous
laser
laser
is going
ablation
to,
has more successful.
you think laser is going to be successful here?
So since it has tortuosity and foam sclerotherapy is
Which are the treatment options which you enumerated are out of this? See, I can see that just above knee or around knee, there is a huge conglomerate of veins. Below that, there is complete tortuosity. This is what I'm looking at.
yes, sir.
Any of your laser treatments is going to help this patient?
The tortuosity is there, so we cannot radio frequency ablation. We cannot be given.
So ultimately, you have many treatment options.
Sir.
Which is the best one, which is going to give you success if deep veins are normal and there is no other cause?
Sir, sclerotherapy and phlebectomy can be.
So we will combine.
If DVT is not there, Tendelberg open surgery can do successfully. Sir. If since the veins
That is
are
exactly what I want to know from you. Because you enumerated so many treatment options for this patient.
Yes, sir.
Looking at this patient, I don't think any one of your treatments that you have outlined actually comes into picture. It is only surgery and combination with ancillary other treatments that is going to come. Answer my last question. What is deworming procedure? Deworming procedure. And when is it done?
Albendazole.
Pardon?
Albendazole is used for deworming.
I'm not hearing you properly.
Deworming, albendazole.
No. I'm not asking about GI tract. I'm asking about varicose veins. It was described in Israel. That also I can tell you. Read it. I'm not going to give you an answer. You are a good reader. Write it down. Take an homework. I'm telling you, it's an Israeli procedure which is done.
Okay,
For varicose veins. Okay?
Yes, sir.
Kanagwell, I'm done.
Thank you, sir. Kanna sir, do you have any closing comments, Ratna ma'am?
What consent will you, sir?
Yeah, Dr. Chopra, please, yeah.
What consent will you take from any patient for whom you would be considering intervention of any form for varicose veins?
Recurrence we should explain, no?
Mm-hmm.
And
And that you may need more than one type of treatment in any patient. And if there are foot varicosities, they will not be addressed by any of these procedures. They will need a separate intervention.
amputation.
Sorry? Foot varicosities do not get cured by these surgeries.
Amputation.
If you
If it is
had a patient with severe lipodermatosclerosis, how will you manage perforators? Will you still be able to make small incisions into a subfacial ligation?
No, ma'am, there is not. It's not possible. If
So
it is fibrosed.
what can be done? What can be done if there is severe lipodermatosclerosis of the whole leg? Then you need to make a stocking seam incision. And then all the veins that are going from towards and crossing the deep fascia have to be ligated.
Yes.
It's called Linton's procedure. Stocking seam incision is made for very severe varieties of lipodermatosclerosis. So, Dr. Khanna, sir.
I think regarding this patient definitely requires almost all the available treatments for the varicose veins. This patient will require the laser, it will require the sclerotherapy, it will require the mini flavectomies, it will require the compression stockings, it will require the medical treatment. So almost all the treatment has to be given to accept a acceptable result in this patient. You cannot go with just one treatment in this patient. Okay,
I
Dr.
think
Yes,
I
sir.
think I completely agree with Kanna sir. This limb requires a proper treatment. Otherwise, it is going to be a disaster. Absolute
Yes.
disaster.
Yes, sir. Dr. Raghavendra, do you have any doubts to be clarified? Now that you have read theory so well for preparing the class, you would have definitely had doubts or any comments would like to be in this patient, would like to ask doubt clarification from the examiner.
So this patient is not willing for any treatment, sir, actually.
Mm-hmm.
And the best treatment what we can
Unwilling
Why
for
did the company
treatment will be
report? Why did the patient report to the hospital? He didn't want
with
treatment.
with dilated veins only, sir.
No, if he doesn't want treatments, why did he come over?
Like since their parents had brought him, sir, and he was not willing for any treatment.
Has he had any? He's had episodes of blowout, isn't it?
Yes, sir.
This patient definitely requires a treatment, no doubt about that. Because if he bleeds from one vein, he may just exsanguinate because of that. So he needs the treatment for that, and that is why you have to carry out, I told you, the multiple type of the combined treatment in this patient. Okay, not just one. So you do a laser also, you do the sclerotherapy also, you do the mini flavectomies also, you give the patient medical treatment, and you do the compression stockings also. So almost all the treatments are required for this particular patient. But he has to be treated.
Yes.
Maybe Raghavendra, you need to spend some time explaining to the patient regarding the need, as both Karna sir and Abhay sir told, the potential complications, right? See, once complication sets in, it becomes more tougher for you to give some reasonably good results. As already you have to exploit more than 5 or 6 choices together for give some optimal result. Sometimes you do staged repair also if you feel you are uncomfortable doing everything in one go. So that is the case, then the patient should be explained. Once it is done properly, he will have a good quality of life. And then being young, he would like to have a good career and something like that. You can consider doing it. But then many times the patient...
One important thing I would like to come in here.
Yes, sir.
This patient is not willing for surgery is one aspect. But you look at his other leg. He has worn some black thread.
Yes, sir.
If you see that thing very carefully, this boy knows that he doesn't want that thing to occur on the other leg. I think you should use that. You should use that. Ask this person why he has worn that black thing. Obviously, to me, with Indian subcontinent, I know that this boy doesn't want this to occur on the other leg. Use that as an issue to settle the issue on the other side.
Yes, sir.
Okay. Yeah. Very important thing. These are small things. I'm just talking through experience that I have. That once you identify him and psychologically commit him that you are wearing something on the other side because this should not happen on this side, get treated. I'll give you another black thread to put on the other leg. That's my take. Thanks.
Thank you.
Thank you, sir. Thank you. Ratna ma'am and Kanna sir, can we call it closer? Rajiv sir, any other points, sir? I think this is one of the longest classes we have ever had. Both the cases, even though taken as a short case in the exam, has now gone beyond the long case. Anyway, good. Both the students have prepared well. Credits to Jyoti ma'am for preparing the students to this level of discussion. Both the students have worked hard for this case presentation. On behalf of the faculty, I congratulate both of them. And we look forward for yet another PG clinics coming Friday. Thank you very much. With the permission of the faculty, we call the session a close. Can we, sir? Can we, ma'am?
Are you still in Harvard?
Sir, I'm back, sir. I'm at indoor, sir.
Oh, okay, fine.
I'm also at Indore.
Both of us were
Or
in the evening.
Ekasrikon, yeah.
Okay, I am in Rajamundry.
Oh, what is the meeting going, sir?
No. I was called to take some clinics out here.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir.
But still, I found time to join you.
That's so very kind of you, sir, in spite of having a tough day, long day with you.
Yeah. Okay. Nice.
Thank you, sir. Thank you, sir.
Good
Thank you,
discussions.
faculty.
And
Yes, sir.
let me congratulate the mentor. She has done a very good job, and both the people have presented quite well.
Yes, sir. Yes.
Yeah. Okay. Thank you. Good night.
Thank you, sir. Thank you, sir.
Good night, everyone.
Good night, faculty.
Thank you,
Good night,
sir. Thank you.
everyone. Thank you, sir.